couldn't remember if it was this event that was snowed out and we had to push it for a couple of days, or that might have been the Georgia Fall. It's like we had our voices. We had voices for Healthy Georgia and Healthy Georgians for UMIP. It's like both of those women are. It's like those names are so similar. There were times that I was like, okay, did I just speak to Laura? Or did I just start with Susan? Because they both call themselves Georgians, and I was like, so now that I know them a little bit better. Last year was the first year that I slowly took over communication roles just with the client. Client absolutely. Yeah. And both of y'all used this building like 3 years, 6 days ago. Got this exact setup. Yes. They live stream. You guys are just recording it and dumping it yourself. James, right out of Sora Medoff's speech. It's a video. Yeah, they're telling me it's good. Good afternoon. Please welcome Georgians for a Healthy Future Board Chair, Sar Medoff.
I was not expecting the walk-up music, but I appreciate it. Good afternoon. Thank you. Welcome to the 15th Annual Health Care Unscrambled. My name is Sar Medoff, and it is my privilege to stand before you and welcome you to our event as the new chair of the Board of Directors of Georgians for a Healthy Future. This afternoon, I want to tell you about someone really special to me, my Uncle Philip. Though he passed away 8 years ago at the age of 63, I'm often reminded of him through my work with GHF. So I want to tell you a little bit about him. My Uncle Philip, he loved going to McDonald's, he loved singing, he loved his best friend Nikki, he loved my grandmother and my grandfather, and he loved riding his tricycle. My Uncle Philip was severely intellectually and developmentally disabled and spent more than 50 years of his life in a behavioral and mental health facility run by the state of New Jersey. Now, I had the privilege of visiting my uncle often, and as a child I used to love going for drives in the countryside. We'd sing as loudly as we could. As I got older, I began to appreciate the exceptional place that he lived in and the incredible staff who worked for the state of New Jersey in this facility. I admired their infinite kindness, their professionalism, and their skill, and ultimately it's one of the reasons I became a physician myself. As a college student interested in health policy, I remember one conversation with my mother after one of our visits with her brother. And she said, "Sar, the mark of good government is how it cares for those who can't care for themselves." I'm going to repeat it. She said, "The mark of good government is how it cares for those who can't care for themselves. It's not how the government mandates, it's not how it enforces, but how it cares." And at Georgians for a Healthy Future, we care for those who are not seen. We advocate for those who are too busy working 2 jobs during the day and caregiving to their children and their parents at night so that they can't come down to the Capitol to lobby their elected leaders. We advocate for the children who are kicked off of Medicaid through no fault of their own, and we advocate for our neighbors who are struggling with mental health crises, trying to find therapists in the far reaches of our state. At GHF, we care for those who can't care for themselves, and every day we remind our elected officials to care as well. Now, 2024 brought some much-needed energy to this fight. One of the things I remember from high school science class is that energy can neither be created nor destroyed. It can only be transferred from one form to another. In November, the energy crackled all around us. Whether in support of Harris or Trump, there was electricity in the air, and now it has to go somewhere. Some see it as a headwind. Nationally, we anticipate challenges to the ACA and private insurance marketplaces. We expect there's going to be renewed interest in Medicaid work requirements beyond Georgia, and there's going to be pressure to trim Medicaid services wherever possible. However, despite these anticipated challenges, this chaotic energy, it can be a source for good. It can be a source for change. New doesn't necessarily mean bad, and this energy can be harnessed to make Georgia a healthier place to live, to work, and to raise a family. At GHF, this energy, the energy that was all around us, can be used to improve healthcare access and equity. So what does 2025 hold for Georgians for a Healthy Future? Here at home, we will be working to extend continuous Medicaid coverage for children ages 0 to 3 years old to avoid gaps in health insurance during these most vulnerable years. GHF will be working to protect health coverage gains paid for by the federal enhanced premium tax credits. And then we will also be supporting a state certification process for community health workers so that we can connect patients to care and improve health outcomes regardless of where you live in our state. To jumpstart our efforts, we're telling stories. We're releasing a new podcast called Health Care on My Mind, and with the first episode dropping today. The podcast will give impacted Georgians and health advocates a platform to share their experiences with our state's healthcare system and offer insights to guide us toward improvements. In a video in just a few moments, you're going to meet some of the people we work with and people we work for. People like Paul Michael, an essential worker in Georgia's Pathways program. Shirthia Jackson, a mother of 4 and a full-time caregiver, navigating Medicaid to meet her children's needs. You'll meet one of my colleagues, Dr. Toby Terwilliger, who's a hospitalist at Grady, and a medical student, Rydia Shah, who have both observed how the gaps in our state's health policies impact community members like Paul and Shirthia. We hope their voices will inform our discussion today and inspire you to take action to help us build a healthier future for Georgia. We will then have the privilege of hearing from Hemi Tewarson, the President and Executive Director at the National Academy for State Health Policy, followed by our great legislative panel. I want to thank you for being flexible with our scheduling today. Much like the legislature just across the street, we operate in a dynamic environment and appreciate everyone pivoting alongside us. Also, thank you to our 3 champion sponsors, Georgia Health Initiative, Hemophilia of Georgia, and Pharma. Thank you to all of our other sponsors. We appreciate you and your support for our work. Everyone here has someone in mind when you think about healthcare advocacy. Every day when I work down the block at the Grady Emergency Room, I treat patients who come to the ER because they have nowhere else to turn. They don't have health insurance because they're a part-time student, a part-time worker, and they fall in the coverage gap. They don't have housing because it costs too much. They can't see their primary care doctor because they work 2 jobs during business hours and they can't make it to clinic after that. That's what I see every day. But today especially, and this afternoon especially, I know that I'm thinking about my Uncle Philip. Who are you thinking about? Now, together, we can and we will push our government to care for those who can't care for themselves. We will push them to care for our neighbors, our families, and our friends as much as we do. Thank you all for being here. Thank you for working alongside us, and welcome to Health Care Unscrambled.
Welcome to Healthcare on My Mind. I'm Kennetta Atkins, Senior Coalitions Manager with Georgians for a Healthy Future. And with me today,
My name is Shirthia Jackson.
My name is Paul Michael. I'm from Stockbridge, Georgia.
I'm Ridhya Shah Daya. I am a medical student at Medical College of Georgia.
So my name is Toby Terwilliger. I am a hospitalist here in Atlanta, Georgia.
I heard about it signing up through the SNAP program, my food stamps, and I went ahead and clicked on, sign up for Medicaid too. And they said I was eligible for the pathways.
How is it meeting your healthcare needs?
I can make appointments, and they tend to be, fairly timely about getting me in there. I only had one issue, and that was when they charged me for something that I didn't know what it was for exactly. And it was totally unexpected to me because I didn't have the extra $50 to pay for a fee that when I hadn't even been there before. So
I'm not gonna lie, where we live, the amount of doctors versus the people ratio is huge. We're traveling at least 2 hours or more to get the specialist because it's so limited here. The medicines needing the pre-authorizations, not getting it in time, that's ridiculous, and that's what we've been dealing with. Just yesterday, my son, he received his new wheelchair stroller, and I've been so excited about that. But he received his new wheelchair, but that chair is $17,000, and there's no way that I would have been able to, get it.
Paul, I saw you shaking your head when Shirthia mentioned the ratio of people to providers.
I lived in a small town from 2000 to 2015. I lived in South Georgia, where Georgia and Florida, Alabama all meet at, and it's like if you need any kind of specialist or anything special, you got to drive 45 minutes, either north, south, or east or west.
Yeah, my son's specialists, they start about 30 minutes away, and as I stated before, the ones that he goes to see on a regular, at least 2 hours away.
If everything goes as it's supposed to, it takes an hour or so. If everything's perfect, on my end is not the problem. It's just actually getting it in the system. That's when the nightmare comes on. It may be, you never know. It might be right at sign on, just trying to sign in. It might not recognize your password, or I was dealing with an expired password last time. So I needed to update my password or whatever. My password had expired, and I needed to, to reset it or what have you. And that took, it was during the week, and it took into the next week before I actually got taken care of, before I actually spoke to somebody, and she actually sent me a link that I could, it was a temporary password, and I had to go through all that, it turned into days, literally. I can assure you that it's not just me. It's got to be something with the system.
Yeah, thank you for painting that picture of just how much time it takes for you to go through that process.
It seems like they update that website more than anything. And and then you end up getting locked out, and then they're telling you, hey, you have to go through all these different steps and stuff. It's a lot. So if you, like he said, if you're not tech savvy or even a little bit, you may very well give up. And the fact there are no offices around for you to go in and see or speak to anyone, and then you get on the phone and you go through the automated system, and then they take you through another automated system.
If you could talk to a lawmaker in Georgia, imagine that they are in the room with you, what would you say to them?
Take yourself from the place that you are, the comfortability of your life, take it and just for once look and see and realize people are needing of these things. It's not like we're just asking because we want it. These are things that we actually need. We need healthcare access. We need access to better doctors. We need access to better just options. We don't need to go through all of these pre-authorizations to get things that we need, because if we didn't need it, why would the doctor even need us to have it to be authorized in the first place? It's more than enough funding, and we need people who are at a higher level than us just citizens to realize that and to go about helping us the best way that they possibly can.
I think that they should make the navigating the system easier. You should be able to maybe call somebody up and have them do it like an online interview. They just ask you questions and they put the information in for you.
We really just need to make sure that the people who need to be able to access healthcare are able to do so, and are able to do so because they have coverage that is going to allow them to go to the doctors or hospitals that they need, and also are able to do so because the act of going to the doctor is not going to lead to financial ruin or financial hardship.
A lot of what I'm learning right now and what I keep continuing to learn is that there's a lot that I will be able to do for my patients in the future, and there's a lot that wonderful physicians like Toby are doing for their patients now. A lot of times physicians and community health providers and other providers and public health officials are kind of limited by policy and also by some of the barriers that they themselves face in being able to provide care. And so something lawmakers can do is reduce barriers to access and kind of support safety net hospitals and support community health providers more to be able to use all of these tools and all of these wonderful officials and workers to be able to provide all the care that Georgians need.
Put yourself in our shoes. Push for the releasing of the funds that Georgia does have.
Please welcome to the stage Laura Colbert.
Good afternoon, everyone. It's very weird to say afternoon and to have it so bright in here during a Health Care Unscrambled. Thank you guys for joining us in the afternoon and instead of our normal early morning breakfast. And if we could please give one more round of applause to Paul and Shirthia for sharing their stories so generously with us, and as well as Toby and Rita. I always learn so much from the interviews and the conversations we have with people across the state. That is really where GHF really pulls our lessons and the learnings in which we ground our advocacy. And so we try to really bring you all just a little snippet and flavor of that at each Health Care Unscrambled, so that you can have a little bit, a little taste of what we are so grateful for from Georgians around the state. I am very pleased to kick off a little bit of our topsy-turvy Health Care Unscrambled today by introducing our keynote speaker. We're doing our keynote before our legislative panel this year, so don't worry, we will get to our legislators. Joining us today from the National Academy for State Health Policy is Executive Director Hemi Tewarson. NASHP is at the forefront of engaging state leaders and bringing together partners to develop and advance state health policy innovations. Hemi has held prior positions at the Duke Margolis Center for Health Policy, the National Governors Association, and in the Office of General Counsel of the U.S. Government Accountability Office. And she brings all of that wealth of expertise and experience with her here today. Hemi and I are going to help set the scene for this new legislative biennial, as well as the new federal environment in which our state will be operating and responding. So if everybody will join me in welcoming Hemi, I would appreciate that. Okay, are we? Yeah, we're on. Thank you. Smooth and easy. Well, Hemi, we wanted to get started this morning and talk a little bit of just very broadly about kind of what our new federal environment will look like. because our state will certainly be responding to that, and our lawmakers will in addition. So can you tell us a little bit about what President Trump and congressional leaders have indicated will be their health policies, priorities, and what do we not know about those health priorities?
Well, first of all, thank you so much for having me here today. I've talked to some of you out in the audience, and I love going in-state. I've been in D.C. a long time, over 20 years, and it really, I think, is helpful to go in-state, hear what the local environment is, and so it's been great to talk to some of you ahead of this conversation. So, I do not have all the answers. I do not have a crystal ball. I'm just going to caveat that. But what I did want to say is the few things that we do know, and they're things you probably, many of you are aware of. I know you have wonderful advocates in this audience that are up to speed on all these things on the federal level. But a couple things we know. I just want to throw out a quick timeline and then talk a little bit about top-line priorities and then how that applies to healthcare, if that works. So next week, on January 20th, D.C. will be overcome with the inauguration. I have been in D.C. a long time. The city changes regardless of who is coming into office. And then on January 21st, we are going to see lots and lots of executive orders. We know those will be released. They're already being drafted now. We don't know exactly what's in them. But I did want to mention those because I think once January 21st hits, you're going to get a lot of information at a very fast pace. And it will help really, I think, identify what are going to be the first on the list, first 90 days of action from the new Trump administration. So a couple things just in terms of what's going to be likely in those executive orders. Healthcare is not on the top of the list, just to be very clear, for President Trump. He is very interested in, as you all know, border security, thinking about energy efficiency, and also economic growth, which is really around extending the tax cuts that were implemented when he was first in office. So that, I think, is going to be really what you see in some of the executive orders. In terms of what Congress is thinking about, Congress, as you all know, they were able to extend the federal budget in a very dramatic, not unlike the things that happen in D.C. often, but a very dramatic fashion at the end of the year. But that federal budget is only extended through March 14th. So Congress will have to act to continue to allow the federal government to operate. There was also a number of healthcare specific extensions, things like teaching health centers, community health centers, funding for all of those different types of programs that were extended through the end of March. So those will also need to be extended by March 31st. So I just paint that package because Congress is going to have to be very active in March in order to address those pieces. How they're going to do that and how healthcare is going to come up in the conversation is something we can talk about right now. What we have all been hearing is we have 119th Congress. New members were sworn in January 3rd. All of the executive decisions have been made around leadership and committees, so those are all on the website if you're interested on who sits on those committees. We have a fairly close margin in the Senate and the House. The Senate is 53 Republicans to 47 Democrats, and in the House we have 219 Republicans to 215 Democrats. I just throw out those numbers because in order to have a one-party vote, particularly in the House, they are going to have to build agreement across everybody, just about. They really can't afford to lose votes. So that's going to be a difficult path, especially when you're suggesting things that may not be palatable to the entire GOP. So a couple things I just wanted to raise. First, in terms of where there are bipartisan interests, I think both in the Trump administration and Congress, where I think Democrats and Republicans could come together, where you wouldn't have to have that straight party vote. Prescription drug pricing. That has been a topic that has been of interest to both parties. For the congressional resolution back in December, there was a slew of reforms addressed at pharmacy that ended up not going into the final bill, but were included in the first version. And those were things like pharmacy benefit manager pricing and transparency reforms, banning Medicaid spread pricing, requiring full rebate pass-through to ERISA plans. Another piece that's been of bipartisan interest has been on health system costs and how that's impacting consumers. I think, one takeaway from this election was consumers are very worried about affordability in their lives, not specific to healthcare, not only healthcare, but just, how they live. And that was really at the top of the agenda when folks expressed how they were feeling. Healthcare is a big part of that. That video, I think, was very clear and helpful in explaining that. And one of the topics that is coming up at the congressional level is the high cost of health systems and really difficulty navigating and paying for health care overall. So there's an interest in how do we reduce those costs, how do we reduce out-of-pocket costs for consumers, and a policy, because we get wonky in Washington, a policy that has had a lot of interest on the Medicare side is creating site-neutral payments, which means anywhere you get service, you will get the same payment. And that, I think, has been an idea that was, again, included in the first version of the CR that was actually not enacted, and it's going to come back, I think, as a topic of conversation because it actually will save the federal government money. So I wanted to mention that, too. The other area, I think, that has really bipartisan congressional support is behavioral health, both on the mental health side, particularly with respect to children. We have seen such a surge in different types of children needing services, and I can talk a little bit more about that when we talk about state strategies and what you all are doing in Georgia. And then also substance use disorder. I think that continues to be a challenge, and that will be, I think, an area of some interest for bipartisan changes. But I wanted to talk about Medicaid. So Medicaid, I think, is a big topic that's being talked about in a lot of different ways in DC. Back in 2017, when we had similar conversations, I was leading the health division at the National Governors Association. So I was in charge of briefing governors on this topic. And so I bring that experience to this conversation, but I also bring the experience I have now at NASHB, where we work with state legislators, Medicaid directors, public health officials, HHS secretaries, state-based marketplaces, who have all been talking about this and their own Medicaid budgets and how they're thinking about how to navigate potential federal changes. So just to give some background on kind of where I'm coming from. So in terms of congressional action and what sort of the president may be interested in doing, clearly want to have money go to border security and immigration policy, clearly want to extend the tax cuts. Those two priorities alone are very expensive. So in Congress, when you all know, when you put through a package, you have to figure out what the pay-fors are. How do you offset what you want to spend in sort of a new policy? So Speaker Johnson of the House has said he's interested in one big package that combines all these different ideas along with the pay-fors on a pretty aggressive timeline. He's throwing out April, which would be very fast and I think would require a lot of work and agreement if that were actually to move forward. But it's just good to know kind of what signals are being put out there in terms of how quickly people might work. So where healthcare is coming up in those conversations is how do we pay for some of these big reforms? Medicare and Medicaid and Social Security are sort of the biggest budgets in terms of spend when you look at sort of across all the different programs, and defense, but defense is not going to be sort of probably part of a pay for. And Medicare, there has been sort of campaign promises that they will not touch Medicare. Medicare will not be sort of part of the conversation, Social Security as well. So that really leaves you with Medicaid. And in terms of the Medicaid changes that are being discussed, there have been a couple of releases from individual members of Congress. There has not been a comprehensive plan released by the Trump administration or by leadership in the Senate or the House. So I'm just sharing some ideas that are being talked about by individual members. So we'll see where they go. But a couple things I'll just share. There is ideas around the fundamental financing of the Medicaid program. So ideas around, do we create per capita caps, which means that there would be a cap to what each state per member would get for the Medicaid program. Right now, Medicaid is an entitlement program. There are no caps. If you have an eligible person who's getting services, there is federal match available, and the state has to put up their match. So that would be a fundamental change to the program. Another idea that's being shared is requiring work requirements across all Medicaid programs. So you here in Georgia have that just for your expansion population through pathways. But there is an idea, would you require it for everyone who would be eligible for Medicaid, which would reduce the number of people eligible. Even though there's a lot of folks working, I think, administrative burden and not everybody's working, et cetera, would be, I think, fewer people. There is some conversations around reducing the enhanced match for the Medicaid expansion population. Not relevant currently here in Georgia, but for a number of states, that would be a very significant change. And there are 12 states that have trigger laws that if that was actually to be enacted, they would no longer be able to do Medicaid expansion. So that would have a pretty significant impact across the country in terms of people who are eligible. There are some other ideas being floated. I was a recovering Medicaid attorney, so I used to help hospitals and states and think about Medicaid financing. So I won't get too wonky here, but there are some ideas around, how states generate their share of funding that the federal government matches, and states do a lot of different things. They can do intergovernmental transfers with local governments or public hospitals. They can impose provider taxes, and that allows them to, use Medicaid funds without having to use their state general revenue because they're getting it from other sources. So there's ideas around, do we limit those so that the federal government is going to pay less on the Medicaid side and the burden is going to shift to states? There's a couple of other things on Medicaid directed payments. That has been, the Biden administration has really, I'd say, opened the door to allowing states to go, most states have Medicaid managed care, but allowing states to provide direct payments from their Medicaid agency to hospitals. Been very helpful to some safety net hospitals, but also there's a lot of other hospitals that have been benefiting from this. I think there's questions around, do we tighten that up, reduce those payments, and again, the federal dollars would be saved. So there's other things, but those are kind of the big level pieces. And I would just say, in all the conversations that we've been having across states, in general, I know Georgia's budget is fairly stable. There are some states that have very significant budget shortfalls that they're addressing. $700 million that they have to make up, $900 million that they have to make up. And it's coming after years of having a lot of additional federal funding flowing from the pandemic. So the past couple of years, like 2020 and on, we've seen an expansion of Medicaid. In the sense of, new types of services being covered, new types of providers being able to get Medicaid match, expanding payments to hospitals, all of those sorts of things. I do think across the board, to the comment, there's opportunity and change, right? It's not all bad. There is going to be, I think, a focus across states, regardless of what happens at the federal level, on thinking about efficiencies and how we can do more with a little bit less. So that is certainly the conversations we're having, and I think in some states, and you can share about the Georgia piece, there's a lot of programs that might have been started with some of those federal pandemic funds and Medicaid match, and the question is, what do we sustain? What has sort of the best outcomes? How do we think about doing things differently that is going to continue to have impact, but maybe not everything that we were able to do post-pandemic? That said, with the sort of tight Medicaid budgets already, if there are these big changes on the federal level, and I say that as an if, because again, we have pretty tight margins in the House and Senate, and these are big changes. If those were actually to go through, they would have very, very significant impacts, as you all know, on Medicaid programs. States are not going to be able to make up the loss in the federal dollars. So the Medicaid program would have to change. And some states are telling us, we hope that doesn't happen, depending on where they are or where they sit. Some states are saying, we hope that doesn't happen. That would really hurt us. We're not sure how we'd be able to sort of operationalize all of those types of changes. Other states are saying, if it does happen, we would need to fundamentally change how we do Medicaid in terms of services and populations covered. So I shared that with all of you because I think right now it's very helpful to have the facts of, as these proposals actually come out. Right now, it's just a lot of conversation. There's not something on the table yet. But as these things come out, really explaining to your local leaders about the impact here in Georgia, what that would mean for not just the Medicaid beneficiaries, but your health plans, your hospitals, all of the other parts of the healthcare ecosystem, so that there's just a full understanding. I will say back in 2017, that was immensely helpful. When, yes, sitting in Washington, you're trying to look across, but hearing all of the local stories and the impact helped folks in DC really understand what it means. So I guess I would just share that. A couple of things I'll mention, then I'll stop talking. Is in terms of HHS priorities, what else might HHS focus on? We still have to wait to see if Robert F. Kennedy Jr. will be confirmed as HHS Secretary. So far, it's on track. We don't know yet. I do think Congress is going to try to deal with some of those confirmations between now and March. So he probably will be in the mix of those to be confirmed if he is confirmed in that time frame. But a couple of things on his platform is about making America healthy again, MAHA, as I like to call it. And there is, there's opportunity in change. I'm just going to say that. There's a couple things that he is really focused on that is of interest to me, chronic disease prevention and food and nutrition. I think those are areas where, thinking we don't spend enough on prevention in this country. My personal belief. And we often are dealing at the end when people have the illness and it's more costly. So thinking about what could really change and investments could change at the prevention side, I view as an opportunity. There are I'll say this, concerns around vaccine reporting requirements and the position on vaccines and how vaccine approvals at CDC through their ACIP committee here in Atlanta have done for a long time. If he's actually confirmed, I think unknown, but certainly lots of concerns being talked about in DC. Interest in rural health. As part of the MAHA platform is how do you think about rural health differently? I personally think we have to have a new model for rural health. Rural hospitals that are, central to communities just don't have the volume to stay open in many communities. So how do you support them? How do you think differently about financing? What other, supports need to be in those communities to sustain people who need services? Drug shortages is one of his areas of interest, thinking about when we don't have something in the pipeline, how do we, because it may not be the most lucrative thing for a manufacturer to invest in, how do we help stimulate that to make sure we're still being able to address those shortages? And maternal and child health, particularly with WIC and nutrition, has been on the list of things that they've been talking about. So I share that as I know that's a common interest for many of you here in this room. The last thing I would say, a conversation, so we have DOGE, which is not an actual agency, but is advising President Trump, Elon Musk, and Vivek Ramaswamy being at the head of it. They are very focused on efficiency in federal government and reducing the federal budget by $2 trillion. That is a very tall order. We will see what comes to pass from that, but I mention that because that's a lot of the talking points right now happening in DC. There's different things to look at, like federal workers and thinking about how to rein in spend. But the things that are coming up in the healthcare space that I would focus on is this interest in how do we use AI to make government programs more efficient? How do we address fraud to make sure that we are not overspending in certain ways? And so I just share that. It's not an area that we work with very much at NASHB, but it's something that's definitely coming up in conversation. So.
Thank you. That was a lot. I took a lot of notes because some of that was even new information, even for me. So it sounds to me like there are certainly some opportunities on the table, but in a lot of ways, the environment at the federal level may make it more challenging for Georgia or other states to address some major health challenges or concerns in state. So that is certainly something we will keep a pulse on here at GHF and certainly keep all of you updated on as well, and especially that core Medicaid piece. So as we heard from Paul and Shruthia, speaking of Medicaid and government efficiency, they both talked about how difficult it is to interact with the Medicaid system, specifically the website, and just, Paul spends at least an hour a month, if everything goes smoothly, filing paperwork so he can stay compliant with pathways. Shruthia, spending also lots of time trying to navigate our Georgia Gateway website for public benefits. I think that kind of underscores what we already saw in the Medicaid unwinding that made it really apparent that our Georgia's Medicaid systems and policies are not working really very well. They're not updated, and they really struggle to kind of meet the demands of current everyday life. So how have other states upgraded their eligibility and enrollment systems? How have they kind of doubled down on efficiency so that people have an easier time getting enrolled and staying covered?
So Laura shared her question beforehand, and I went back to my team. I said, who is the model state? We do not have a model state, but we have a couple of ideas that we have. We talk to states all the time about this question and kind of how they're doing an unwind and how they're doing post-unwind. So I'll just say a couple of stats. We have 79.4 million people enrolled in Medicaid. 2 million are in Georgia. That's a lot of people across the country. This year, enrollment declined by 7.5% as a result of Medicaid unwind, and people, whether they're still eligible or not, that number is not 100% clear. And we expect at least a 4.4% decline in 2025. So one of the areas that our state leaders, we have a children's coverage network that we have sponsored at NASHB since the enactment of CHIP, where we have all states, actually all 50 states participate. It's very active. People talk about, CHIP is now, merged with Medicaid, and there's a lot of different ways. We call it children's coverage now. And we talk with them every couple weeks to say, how are you doing? Like, what are the strategies you're using? How are you getting kids back on the rolls? I think particularly relevant for Georgia, most of your Medicaid folks are children. And they would say they have shared a couple of things. There's the continuous eligibility requirement that went into effect this year for 12 months. So children have to stay on the roll for 12 months. Some of the states are still implementing. They're finding that helpful. They're trying to upgrade their systems to make sure that is actually happening. So there's the policy and then there's the implementation. Sometimes not all the same in the same moment. The 1902E14A waivers, just to get a little wonky, which were flexibilities provided by CMS to states during the redeterminations, have been helpful for some states. I know Georgia had 7 of those or something like that. And some states are trying to continue those. So those are like, how do you increase the ex parte renewals, which would really allow, continuing coverage without folks having to go back in and do a whole application. Again, back to your simplification point. I would say it's interesting in these conversations we've had with state leaders. Some states came to us and said, oh, we weren't really defining ex parte the same way that CMS is. We were actually requiring individuals to go back and put things into their forms, which was actually not easier for them when we actually did consumer surveys. So I think there's an interest, at least for some states, of thinking about how do we get to true ex parte with our systems and make sure that we're doing that so that we have accuracy and simplicity for our folks. There were other things that they did through the waivers, like contact information, MCOs helping enrollment. A couple of things on the data side. There have been some states that have done a really good job streamlining transitions with marketplaces. So I just share a couple of states, Maryland, Massachusetts. They have done a really good job sharing the data in between those two programs to ensure that if someone is falling off of Medicaid, they're transitioned to the SBMs. And they actually sometimes find, they are still eligible for Medicaid, so they send them back. So that data transfer, I think there's been some investments there. There's been, it sounds like Georgia's been doing some of this, data sharing with programs like SNAP. So some states have gone all in and tried, like Kentucky, tried to create a very integrated eligibility system where SNAP, WIC, Medicaid are all under one roof. That's a complicated and longer term project, and there's some challenges with actually getting the data systems to talk to one another effectively. But short of that, there is a lot more investment in the data sharing piece and trying to get someone who comes in for SNAP, like you shared on your video, become aware that they're eligible for Medicaid and making that process easier by pulling some of those application parts and transitioning into a Medicaid application. And the last thing I would say that folks really said was super helpful was really engaging consumers more. So I'll throw out a state that's not generally one probably as a model for Georgia, but Washington State. Washington State, and this is in a way where it could be a model because it's about the application process and consumers. Their consumers kept saying, your application process is too hard, it's too long, you're requiring us to have signatures, it's just too hard for us to do it. We get kicked out and then we don't go back in and finish. So they had a really focused consumer group, give them input along the way as they refined their application process. It sounds boring and not that high tech, but really that was some of the better engagement they've had in the past couple of years for folks saying, you helped me make this easier, and you actually listened. So I guess I just share something that's not, having to do a huge data system reboot, and something easier that people can follow. The other thing I would just say is language accessibility came up quite a bit, how to help that. And the community outreach strategies. So some of the states who are trying to improve their children's coverage, some of their school events have been really successful. I don't know where Georgia is in that, but really partnering with community-based groups and doing things like events at schools, because some of the pure remote, putting up ads on radio and TV was not penetrating. But when they actually went to a school and they had someone there and a worker that actually helped people sign up, they were like, oh, we actually had a much better uptake, especially for the kids. Because people want their children to be covered, but they needed just an easy access point. So I share that. The other thing I'll just say too is using text message. So I don't think I fully realize how few states actually use text message before the redetermination process. And I'm like, my gosh, we're in 2024. Everybody texts all the time. Like my daughter say texting, you're so old fashioned. Like we're only snapping. I mean, so. We're behind already, but it really is interesting how many states just started texting as a result of this redetermination process. And I do think that shines a bright light on how antiquated some of these processes are and how we do need to reboot. And so some of the states are working on making their portal more accessible for mobile. So not everyone's going to go on their computer. How do you do it on the phone? You can get a text, you can hit the link, you can then go to the portal and then fill out some of your pieces all on your phone. And if you think about how we all operate, right, how we all order things, get things done, it's through our phones. So that's something I wanted to share as well. And the last thing I would just say is target outreach to specific groups. Some states have done a lot of data analysis to see geographically, where are we not hitting our targets? I'm not sure what you're doing in Georgia, but using those analytics to figure out where do we need to invest more in the community-based organizations in those locations.
Yeah, that's. I looked at the table where a lot of our GHF team is sitting, and I saw Deanna, Melita, two of our sisters, nodding along as you mentioned several of those challenges and the improvements states have made. I think we have also found school-based events to be really helpful, and of course having in-person community-based assistance is something GHF holds as a core value and something essential for statewide reach. And that I love all of those ideas. I hope one of our DCH officials is here and is taking notes, and DFACs. So another kind of streamlining that other states have done, and GHF is supporting here in Georgia, as well as a cohort of other partners, including our Voices for Georgia's Children folks and Gears. There you are. Is adopting continuous coverage for children 0 to 3 or 0 to 6. How is that going in states that have adopted it? How can that help to reduce gaps in coverage and improve access to care?
Yeah, it's a great question. So Oregon was the first state to actually get approval from CMS for multi-year continuous eligibility. And they had to convince their lawmakers because, whenever you're the first state to do something, there's a lot of questions, regardless if you're red, blue, or purple. How much is this going to cost? Is it going to make a difference? Why are we doing this? So we worked with their folks while they were going through that process, and it was interesting. What they were able to predict based on their analytics, and they're starting to see some returns on that, is improvement in access to care. So looking at Medicaid claims for those kids that are now eligible through the continuous eligibility window, there's an uptick in them accessing services based on claims data. What they haven't quite figured out yet, but they are predicting that there'll be better academic outcomes with school readiness because those kids will be in school more. They don't quite have all the evidence for that, but that is, I think, the plan. And the reduction of administrative burden. So they were able to estimate in terms of having to do the redeterminations every time and the cost of that actually would be reduced as a result of having these kids eligible. And they also did some predictions that these kids are actually truly eligible. It's not as if, the likelihood that their parents are going to make twice as much and they're no longer going to be eligible for Medicaid. So those are some of the data points, not all of them, but some of the data points Oregon really worked hard to kind of build the case. I will say where we are now, we have 9 states that have approved 1115 demonstrations for multi-year continuous eligibility. And they are, is there?
Signaling our slide.
Oh. There we go. Okay. So you can see that on the map. We didn't put the names of the states, but if you can guess. And some of them are 0 to 6, some of them are 0 to 3, 0 to 5. But you can see it's an interesting mix from across the country. There's 3 additional states that are in DC that are under development. They're in conversation right now with CMS. That's California, DC, Illinois, and Ohio. There are a couple of others. I know Georgia being one of them. You're still thinking about kind of what the proposals are. So I would say on this point, 1115 demonstrations have always been a tool for states. I do think this new administration is going to want to give states flexibility. That was true in the first Trump administration. I think it will be true again. They like state ideas. They want states to take the reins. They want them to run their programs, perhaps even putting in more money, which we talked about earlier. But I would say, so we'll just have to see what they're going to do with 1115 demonstrations. I think this particular policy, there's uncertainty. Whether this new administration will approve, we don't know yet. We'll just have to wait and see.
Thank you. And for those, I guess I should have included this in my question. For those who are unfamiliar with kind of that Medicaid 0 to 3 or 0 to 6 policy, that would mean that when a child enrolls as an infant, when their family gets them enrolled in Medicaid as an infant, they would not have to renew or redetermine their coverage until they hit their either 4th birthday or their 6th birthday, depending on how long that continuous coverage policy is. So 0 to 3 or 0 to 6. And so really hope that that gets some legs during this session, and we think would be really impactful for kids here. So while we're on Medicaid, youth and child mental health has been a really important focus of our state leaders over the past several years. I'd say it's got a little bit of a bump after the Appalachia High School shooting this past September, and so they are paying particular attention to how we are supporting kids and youth with mental health programs and supports. Medicaid can be a really powerful lever for helping to intervene around this. So can you talk about kind of other state efforts, programs and policies that have had particularly positive results and been effective?
That has been a challenge for states across the country. We have a HHS Secretaries Network that we run that has over 35 states, and we ask them what's the topic they want to focus on. It's been workforce and children's mental health. So it's really, I think, a challenge that no state has really solved, but there have definitely been some innovation and ideas. So a couple things. One is about integrated care. So I think there's an interest in thinking about there's different levels, right, that children need. There's the lower level, and there's been a real surge post-pandemic of the need of the lower level of mental health services. And then at the higher, the really acute, severe mentally ill, complex populations, kids have been stuck in EDs and in other inappropriate settings of care. And there's actually a number of, I hope Georgia's not one of them, a number of states that are under litigation now and having to make a lot of change because of the litigation. So because of those issues. So those are like on the two ends of the spectrum, I think, where states are working. I would say I'll throw out 2 states that decided to try to do something through their managed care plans. Ohio and North Carolina decided that, particularly with foster youth and children in welfare, those kids had some of the most complex cases, and they didn't have a parent to advocate for them to help them navigate the system. So they wanted to focus on that population to try to help figure out how do we better transition them between settings of care when they have crisis. So they actually have specialized managed care programs with specific services to coordinate for those kids, and they have particular plans that just bid on that piece of the package. So they're plans that are just going to be focused on the child welfare kids who have behavioral health services. So it's almost like a little bit of a carve-out. We have other states that have been thinking about primary care offices, so on the other side of the spectrum of the lower level, and thinking about how they provide and coordinate with the Certified Community Behavioral Health Centers, or CCBHCs, that are popping up across states, how do you better build partnerships between the CCBHCs and the primary care physician, whether they're part of like a bigger health system, whether they're an independent primary care doc, or even if they're in a community health center and they don't have mental health capability. So they have been trying to build sort of MOUs and partnerships and a much better referral system for those folks so those kids that maybe need a lower level of care and can have a better referral, because often it's like, where do you send them? I would say crisis response, just to get back to like, how do we get these kids out of the ED and whatnot. A couple of state examples. Wisconsin decided they had to build youth-specific crisis stabilization facilities. They said, we just don't have enough beds in what we have. They're not the right types of services that they're receiving, so they're building. There was some pushback from advocates in that state who felt like you need to build more community-based care, but I think Wisconsin felt like we need an option for kids who really need to have some inpatient. West Virginia requires their specialized Medicaid managed care plans for youth in foster care to pay for a specific number of beds at crisis facilities, even if they're not being used. So they're reserved. So when a kid comes into crisis to an ED, there's going to be a reserved bed for them that the managed care plans have paid for, which is sort of interesting. I would say the other thing that we noted, so we had a conversation around this during our NASHB conference with Medicaid directors, and they said one of the things, and we talked about out of state. I don't know if this is going to be true in Georgia, but one of the things that was coming up across the conversation was mental health inpatient facilities get paid more to have an out-of-state placement than an in-state placement. So across the board, there were a lot of concerns about the in-state placements being at a lower level and being rejected in favor of out-of-state, which for kids is a real problem because they're not close to their families. So we've been having conversations sort of at the federal level too about like, how do you change the payment incentive there to really disincentivize that problem and think about how to expand access for the inpatient services that are needed. And the last thing I would just say is the pediatric behavioral health workforce. That is sort of underlying all of this of like, do we have the practitioners in these various settings of care? And we can talk about school-based in a minute, perhaps. But just outside of school-based, there's, I just wanted to mention community health workers, because I know Georgia just recently got approval through their LUM 15 waiver to have community health workers serve as part of your rehab benefit to address behavioral health services for adults and kids, I think. But I would just say we have seen over 25 states now invest in community health workers. Just as one example, they're not the solution to all behavioral health needs. I'm not suggesting that. But just as one of the extenders and connection to community, it has really been a lightning rod, I would just say, across states. We created a network where we started with 10 states. We now have 48 states because they're all interested in figuring out how to engage community health workers, not just in behavioral health, but more broadly. But I use that example because I just wanted to call out one state, South Dakota, who has been doing this for a little while. There are challenges on how you certify, how you pay for, and how you get people in the door, and how you don't incentivize people to be social workers. That's come up too. If you pay more on the community health worker side, then they're not social workers anymore. That happened in one state, and they're like, oh no, we're losing our social workers. That's bad too. So it's a balance of figuring out how to do that. But South Dakota has done a really good job. They're a very rural state. They don't have enough practitioners. They're like, we're never going to recruit enough to South Dakota, particularly in behavioral health. They really engage their community to help design how the community health worker program should work. They have it through a state plan amendment on the Medicaid side. They increased the reimbursement. It really helped the uptake, which was very slow initially. And they're tracking claims data and mapping to see who is serving what person where, so they can understand how community health workers are actually being used. And then they're going to create impact stories to really define, like, are people getting better access? Is there an ROI? Like, how do we think about this? So I just call out that one example because they've had a little traction.
That's exciting, and I love an example from a state like South Dakota. Like that helps get to that rural piece and that especially under-resourced communities piece, and that's certainly something we can learn from. And the out-of-state issue in inpatient settings has come up here in Georgia. I can't remember where Stan is sitting, but he might tell me later if we've resolved that issue. I feel like there's been discussion about reimbursement rates here. Still kind of in that behavioral health realm, as you mentioned, there's been a lot of focus on, in Georgia, I think we've actually done a pretty good job of developing the crisis end of our system of care. But in the prevention or early intervention side that can be more community or school-based, we have a little more work to do. We do have a slide, my AV folks, for the Georgia Apex program. There we go. So that's like, I'd say, kind of our Georgia's shining star of a great school-based program that is functioning and doing a really fantastic job here. But what have other states done to really kind of build up that earlier intervention piece so that our system of care is kind of complete from tip to tail?
A lot of focus on school-based prevention because the states that we've worked with, we have a children's behavioral health project that's active now. They feel like that's where they're reaching children in a more effective way. So just across the country, 25 states now have implemented policies that allow schools to bill Medicaid, regardless of whether the children have an individualized education program, an IEP. And it's been interesting to see. There was some resistance, frankly, from schools not wanting to bill Medicaid. It's very complicated. So there had to be, and I'm not sure where you all are in Georgia, but there had to be a lot of support in how to do that and resources spent. And the federal government had some resources there too with grants. But I would say a couple of other things in terms of how schools have been effective. I'll just throw out South Carolina as one example. They cut their school mental health counselor to studio ratio in half after increasing Medicaid reimbursement rates for school-based mental health counselors and giving the schools more flexibility to hire or contract with mental health providers directly. And they have reported that has really increased the ability for kids to get more individualized attention because the counselors were so overwhelmed. I'm in Maryland. My child is at a very large Maryland school. There is no attention. So I think it's really important if there are counselors and you have kids that have mental health needs to have that. Colorado is another state. They implemented a policy change to allow Medicaid reimbursement for school-based behavioral mental health services provided to children and youth regardless of whether they have a diagnosis, so they really opened up the ability to bill. Yes. And New York said on the commercial side, payers cannot pay less than Medicaid rate for school-based behavioral health services because there wasn't parity and there was a much lower payment rate, which then disincentivized the provision of services. On the screening side, Illinois is a state that passed a law requiring a study on universal screenings in school, and they conducted a landscape analysis to think about, like, okay, if we do universal screening, what does that show us? Do we have the referrals needed? Does that help us on the prevention side? And then I would just say the providers that are being used, you guys are on a path here in Georgia for that, but states have had a range of services and providers that are connecting to schools. So there's a couple of things there. Oklahoma established guidelines for schools and behavioral providers to establish MOUs on crisis service delivery. It sounds like you're doing well on crisis, but they really tried to figure out, like, how do we have those agreements in place ahead of time so that the schools know what to do. And California is really doubling down on peer supports in schools and really providing pilot grants to help with that. So there's a couple of examples.
That's fantastic. I would love the Colorado example of having school-based billable services regardless of if a student has a diagnosis. That's kind of touches back to one of our speakers at last year's Health Care Unscrambled about kind of the need to make more kids eligible for Medicaid-covered mental health services, including by kind of eliminating that diagnosis requirement. I love that. So we know that one way to help kind of boost and support mental health is to make sure that kids and families are housed and have enough food to eat. There has been some really interesting work in states across the country through what are called health-related social needs waivers. And so what is going on with those waivers? What might these look like under the Trump administration? Kind of where does all of that stand?
We have had a 3-year project on these waivers with a focus on housing and nutrition. So we've been talking to a lot of states who have been trying to get approval, implementing, et cetera. So I'll just share from that experience. So the Biden administration has been very committed to approving these waivers, and they still are. They're trying to push them out the door at the end of this administration, you'll see. So hopefully I have the latest numbers, but who knows, maybe today someone else got approved. Right now, there are 16 states, and I don't know if the map is up, 16 states have received approval for these health-related social needs waivers, and they focus on expanding Medicaid reimbursement for housing, nutrition, climate and extreme weather, and infrastructure support. So There have been waivers in the past that provided pieces of this, but really one of the new pieces is 6-month rental assistance. Medicaid has never paid for that before, so that is new. And the climate and extreme weather piece is also new. The infrastructure payments, waivers in the past from CMS have provided that, but it has been key, I think, to actually really allowing these community-based organizations. Do you want to chime in on something?
Yeah, I was going to ask you to kind of detail what infrastructure means.
Yes. So money that can flow through the state that can be then provided to the community-based organizations that need to do this work. So Medicaid agencies don't do food and nutrition or domestic violence or housing, and so they need to partner with community-based organizations to then actually implement successfully all of these different programs. And so the infrastructure money is allowing states to then give that money to those community-based organizations, help them build the functions. They have to learn how to bill Medicaid, which is a whole thing in and of itself, good or bad. They have to be able to, navigate all those administrative requirements, and so that's what some of that infrastructure money is going towards. I will say it's on the housing piece. We will see again how this administration will continue with these types of approvals. Again, uncertainty. I will say, interestingly enough, North Carolina is one state that got approval for this type of waiver under the first Trump administration. Not the short-term rental assistance piece, but some of the other pieces. So who knows, right, what would be possible? We have heard that the infrastructure payments may no longer be an option moving forward. The short-term rental assistance may no longer be an option. But only time will tell in terms of really understanding that.
Thanks. So we're going to switch gears a little bit. We've been talking a lot about Medicaid and kind of our public systems. But tomorrow is actually Georgia's very first, Georgia will close its very first open enrollment period under its new state-based marketplace, Georgia Access. Our enrollment is looking fantastic, and I think we have a couple of slides on that. So how have other states, and this is Georgia's first year, we're new at this, how have other states supported their SBMs to ensure that they really work for consumers, they're providing quality, affordable plans, and that that affordability piece is really central.
I love that we're talking about this, and congratulations to Georgia for ending their first open enrollment period at state-based marketplace. So at NASHB, just to give you some context, we host a state-based marketplace network, and we have since 2014, where all the state marketplaces come together and learn from one another in terms of best practices and how to really make sure they're continuing to ensure access to coverage. So Georgia's a member of that. We're great to have them on board, and it's exciting to see all the work that's gone into it. Really good people at the helm, and really, I think, good work being done to try to make sure that you all are successful. So I would say, I just want to talk about the numbers for a little bit, because we are at a historic moment, frankly, for marketplaces. And we spend a lot of time in Ashby thinking about marketplaces, so thank you for giving me this few minutes to talk about it. So last year, there were over 21.4 million Americans enrolled in marketplaces, the highest ever since the inception of the marketplaces. This year, we're on track to exceed that. Open enrollment is not even closed in all the states. Some are going through the end of this month, some are going into February. We're already at 23.6 million. So we're already outpacing last year's. And that includes 3 million new people to the marketplace. So that's a lot of people that are new who have not had marketplace coverage before. Georgia has over 1.5 million people already enrolled, which will probably be your ending number since you're ending tomorrow, but who knows. And Georgia is the second largest state-based marketplace. I just want to be sure you all knew that. Second only to California. And we know how big California is, right? They're an outlier on everything. So we were really surprised to see those numbers and really encouraged to see your open enrollment numbers for this year. So yeah. Go forth and do great work there.
Cheers to our enrollment assisters in the room.
Yes, excellent work. You're making a difference, clearly, because so many people are enrolling. The other thing I just wanted to maybe touch base on, and we could maybe go to the next slide, is some of the reasons for this historic enrollment. And I don't know if the next slide is up. Oh, maybe it's... Okay, is it? Okay, I can't read from here. Yeah. Okay, there we go. So we have in place since 2021 enhanced premium tax credits. So there was already subsidy help for people who are at the lower income levels, under 250% of the federal poverty level. Given the pandemic, in ARPA, the American Rescue Plan Act, there was actually a change to that, and then it was extended through the Inflation Reduction Act, the IRA, not to get too wonky, to say that people who are even above those levels can get help with their premiums and being able to enroll in the marketplace. Big dollars behind that. A lot of people qualified, people at even, and 400% of the federal poverty level. That is not like, people think it's a lot of income. It's not if you have a family of 4, et cetera. So I think in terms of how much the marketplaces cost, it made a big difference. So I just wanted to call out, in 2024, 9.6 million more individuals received APTCs compared to 2021. That's a lot of people. And on average, consumers were eligible for $59 a month more in APTC. And in the rural areas, the increase was $74 per month, which was a savings of $890 per year. And so if you just look at kind of how much did that impact premiums, average premiums for enrollees fell by 32%. And 44% of consumers, nearly 9.4 million people, selected a plan for $10 a month or less after APTC. So that really has enabled people to learn about the marketplace, be enrolled for coverage, and unfortunately, these enhanced premium tax credits are scheduled to end by the end of 2025. So if Congress does not act, there will be many, many people who will no longer have access to these subsidies, and there's estimates that 4.4 or 5 million people may not enroll in the marketplaces. So big concern, obviously glad it was on your list. I heard earlier that it's going to be on your list. We're certainly working for that at NASHB. We don't lobby, we educate, just to explain the implications. So yeah.
Yeah, for folks in the room, you will see that on our policy priorities list. We will certainly be advocating to Congress to take that step to renew the enhanced premium tax credits. We are also educating our state lawmakers about the impacts on our state marketplace if Congress does not act and what our state options are. So you will see some materials and education from us about that. There is a fact sheet on the materials table about that for folks who are interested.
Yeah. Do you want me to talk about a few strategies?
Yeah, please.
Yeah.
A few strategies that other SBMs are using to really get to consumers.
Yeah, so we have the enhanced premium tax credit. It's a big piece of it, but there's others. What I really like about state-based marketplaces is they have flexibility to target their efforts to their communities. So, so we've really seen a lot of that in all of the work that we've done all these years with the state-based marketplaces. There's been some really interesting work on website redesign to be more consumer-friendly. Thinking about like fewer clicks, streamlining options, better shopping tools. Idaho is a state that spent a lot of time working on that piece and has seen they've done really well. My Health Idaho, they've had really interesting campaigns and people have liked it. More investment in consumer outreach, again, seems like obvious, but so important, particularly for targeting communities that may not be as aware, rural communities, small businesses, limited English proficiency. Some states have really looked at their analytics to see like, who are we not reaching? I have found them to be very innovative because, in the early years, they had to be scrappy. They had to get people to enroll, to survive, and so they really had to develop in a way that Medicaid program doesn't in terms of reaching people. So I would say relationship building with community partners as well as agents and brokers to reach new audiences. So I think that's an important piece. A couple of SBMs have implemented easy enrollment programs. So they've coordinated with their state tax agencies to enable enrollment based on state tax filings, just to make things a little bit easier for folks. Consumers who attest they are uninsured on tax forms are automatically determined eligible for coverage through Medicaid or marketplaces. Consumers can opt out. There's a number of states doing that. Improved operational efficiency. Some SBMs are looking at the use of AI. Some SBMs are looking at, do we bring in the call centers in-house and not contract out? Idaho, DC, California, Maryland. They're reducing reliance on vendors and really have had some success, actually. Then there's also kind of the insurance market, and so some SBMs have been thinking about how do we improve insurance product offerings. Again, these are the more mature SBMs that have been around for a little bit, who've like kind of gotten the operational pieces down. So it's like next generation, but they've coordinated with their Department of Insurance to think about like how do we want to build these packages to ensure there's a standard, really strong plan. And some of them decided to eliminate or reduce cost sharing for certain population health outcomes. So, for example, DC, Minnesota, and Massachusetts eliminated cost sharing for diabetes care because diabetes was a real concern, and it helped increase access to services actually through that. Massachusetts targeted asthma and heart disease. So again, just some ideas, like as you know, you get more data and you understand kind of your market. Things that California always is doing something really innovative, but I don't hold them out as an example because no one else could do what they do. And then the last thing I would just mention is you need state dollars for it, but they have been implementation of direct subsidies an affordability program. So some states have decided, we really want to help child care workers or caregivers. That was DC and Connecticut. Some folks wanted to focus on young adults to get them enrolled. Some focused on tribal nations, New Mexico. There are some that have enhanced cost-sharing reductions, California, Colorado, Connecticut, New Mexico, Vermont. So there have been sort of programs like that. I will say I get this question frequently from like national news reporters, and they're like, oh, well, states have these programs. If the EPTCs go away, states can make up the difference. The answer is no. You're talking about much smaller dollars, particularly in tight state budgets, but there have been some targeting of those to try to reach certain folks.
That's really cool. I didn't know about the kind of that direct subsidies and very specific assistance. We have reached the Q&A section of our agenda. So if folks have questions for Hemi, would love you all to raise your hands. Carmen and Courtney are going to bring microphones around. Perhaps while we're waiting on that, I know one other thing we were hoping to have time to chat about is as our public health system. And maybe I see a few questions popping up, so we'll keep this short, but what investments or supports have other states made in their public health systems, especially following COVID, really after we saw public health stretched and maligned in a lot of ways, and so how are other states grappling with that?
Yeah. It's a great question. Public health, public health. What you want to hope after a big pandemic is people all are like, oh my gosh, we need to invest more and think about all the new innovation. That hasn't really quite happened. I think COVID was so painful for people, they wanted to put it behind them and kind of move on. And that certainly happened across states. A couple of highlights, though, and bright spots I just wanted to hold out for you all. Indiana is one that we hold up frequently. Indiana decided, the governor actually decided, we need to learn from what just happened. It was very difficult. We clearly underinvested in our local public health. They have a decentralized public health system. We underinvested and didn't have the capacity to respond when we had a crisis. We should learn from that and think about how we want to do things differently. So they created essentially a public health commission, and they had key legislators, they had business leaders, they had consumer groups, they had state public health officials, local public health officials, all in a group. And commissions, sometimes, okay, you have them and things don't happen. This was a really powerful commission. They really spent the time working and coming to agreement, and they all signed off on a set of recommendations. And the reason I share that story is, as a result of the release of their recommendations in 2022, the following year, their legislature approved an unprecedented for their state 1,500% increase in public health funding. Approving like $225 million for local public health departments. And they focused on a 4-to-1 investment in public health intervention with a goal of prevention, a focus on prevention rather than treatment. That had not happened in Indiana. So they really took it seriously. I'd say one other example, and I'll stop talking so we can get to the questions, is the bringing together of public health and the health system. They are two different worlds. They had to come together during COVID because you needed people to get vaccinated, you need to get the word out, you need to get resources. But then those partnerships have sort of slowly, maybe not been as robust because we don't have a crisis. So there's a couple of states that really double down to say, how do we continue those types of partnerships? And I just call out Virginia as an example. They created a partnership for Healthy Virginia to coordinate the efforts between the Virginia Hospital and Healthcare Association and the Virginia Department of Health and local health departments, local jurisdictions, the medical community, to really think about, okay, like by geography, where do we have the biggest challenges where we can work together? How do we make sure the funding is being distributed in a way that makes sense? And how do we kind of keep that collaboration going? So those are just two examples.
I love it. We'll start over here with Courtney and Ellen, and then we'll move over here.
Hi, Ellen Yeager, Georgia Advocacy Office. So the CDC has done some incredible work with very young kids. And although I greatly appreciate the talk about mental health in the schools, when you talk about prevention, sometimes even that's on the late side. So are there any states that we could look at and have a discussion about what I call real early intervention and prevention, and that is with kids who are 2 and 3 for so many reasons. And we know if kids aren't reading by 3, the chances are there's going to be some serious problems if they don't have a vocabulary in which to communicate. So are there states that are looking at kids that young and recognizing that's where you start?
Yeah, and it's a state that may not be the best model for Georgia. I'll just share that. But Massachusetts is a state that we always call out. They have made a lot of investments in mental health services across the lifespan, but also really focusing on the time frame that you're talking about, the early kids. And they have made that a priority in terms of funding, in terms of their program, in terms of their coordination across agencies. So, you know, when you have sort of SNAP, WIC, Medicaid kind of working together, how you reach those families. The other thing I would call out is there are some states that are thinking about, this is more on the postpartum side, where, you know, there's this new 12 months of coverage for women who have just had children, and almost every state, 48 states now have gotten approval for that. And then the question is, like, what do you provide during that time period? And different states are focusing on different pieces. Some states are trying to focus on the mental health component, and that would include not just of the mother, but also of the child. And I call that out because when the mental health of the mother deteriorates, it impacts the child, right? So it's a collective. And so there have been some interesting initiatives around home visiting. Home visiting can be a little bit expensive, and it's hard to have it widespread across an entire state, and particularly in rural areas. But there have been some states that are doubling down to think about, as part of that postpartum coverage, do we do more with home visiting and have a mental health component and capacity to those services? Just two examples.
Thank you for the great question.
Excellent presentation on a complex matter. Thaddeus Lynn, private practitioner in Sandy Springs, Georgia, here with Georgia Academy of Family Physicians. I've got 2 questions. One is regarding Medicaid. Is there some kind of way we can implement a program where that would be a work-based program for those that qualify, thereby helping the taxpayer to assist the problems in terms of parity for health care? And question 2, there are nearly 5 million Georgians without access to mental health care. And I know that we can kind of focus on problems such as anxiety, depressive disorders, substance abuse, suicidal ideation. If there's some kind of program we can start whereby we can take the providers that we have, especially in Georgia, because we're second worst, only beat by Texas, followed by Alabama, Florida, Mississippi. Is there a way we can implement a program whereby we can take the providers that we have, which are in short supply, and focus on those main mental health issues to address them, and thereby giving increased access to mental health care?
I might take the second question first. So Georgia's not alone. I hadn't realized you're only second to Texas in terms of being worse, but there are other states that have significant challenges there in terms of access. So I'll just share the conversations we've had with other states and what they're thinking about. So you have a limited number of providers, and to your point, there's not going to be a huge influx of new providers coming into Georgia to provide those services. A couple of states have decided to go in different directions. Some states have decided we need to increase the Medicaid reimbursement rates for those existing providers, so more of them will take Medicaid. Whether that's applicable to Georgia, I don't know, but that's certainly some states have taken that approach, and they've seen some uptake in investment. Other states have said, how can we use like a hub and spoke model so that we have, particularly for rural areas, those more rural practitioners who need to have specialized mental health services, and there's not a practitioner that actually is going to go out there and serve. Give that support to that, primary care physician, et cetera, in those areas, so they feel like they can at least have a place to have kind of a telehealth referral pattern to help expand the current workforce and what it's able to do. And they're going out of state too. It's not just within Georgia for those telehealth models. Again, maybe something you're already doing. I don't know.
There is some of that happening already, and Georgia actually, our legislature last year made some big investments also in the Medicaid reimbursement rates for mental health providers. Those have just gone into effect in July, so we're kind of in the beginning stages of that.
Yeah. And then the last thing, I don't know where Georgia is on that, on CCBHCs. Do you have, how many of them do you have so far?
Yeah, so for folks who are unfamiliar, CCBHCs, let me see if I can get all the letters right. Community certified community behavioral health centers.
Very good.
There we
yes.
go. These are like federally qualified health centers, but focused on mental health. Some of the CCBHCs are also FQHCs. And Georgia's actually been doing a really fantastic job of making the transition from our prior model of CSBs, community service boards, into the CCBHC model. And what's exciting, I think, about CCBHCs, and you might have something different that you think is exciting about them, but for me, it's the payment mechanism. So the CCBHCs are not only reimbursed for the mental health service they provide to a patient, but also provided for wraparound services. They're paid to make sure that that person is stably housed or can get to the pharmacy for their medication, and those kinds of like in-between pieces that often fall through the cracks and make it hard for people to maintain their mental health.
Yeah, great. No, I agree. So.
Thank you.
And then he had a question about the work requirements, and I wasn't sure, like in addition to pathways, or I just wasn't sure about that question.
I wasn't. Yeah.
Well, I don't know how elaborate you want to get into the work requirements, but I'm just, even walking into this building, I saw homeless people. I mean, I think that there's a job out there for everyone. It may be sweeping the street, picking up trash, but these are things that we pay state workers to do. And we can take those dollars and put back into healthcare if they're willing to, partner with us and work and do those types of jobs, and with an emphasis on preventative care.
Yeah, so Georgia is the only state that has an active work requirement for your expansion population currently in effect. But I would say what some other states have done, short of making work requirements a mandate for eligibility, there have been other states that have paired supportive employment with Medicaid eligibility, which has been, Kentucky's a state actually, that built a really interesting partnership. So once you're eligible for Medicaid, you have referrals to employment supports to help people figure out, like, what are you able to do, what training do you need, what jobs are there out there that you could qualify for. I haven't seen the latest evaluation results of that program in Kentucky, but there's a couple of programs like that. So, and it kind of just depends on your philosophy. Georgia, you're requiring it for your expansion population. Other states, you're eligible for Medicaid first, and then you're able to get those employment supports afterwards.
Yeah, Montana's my favorite example of a supportive system. I think we have time for one more question over here from Debbie.
Good afternoon, Deborah Kibbe with the Georgia Health Policy Center. Hemi and Laura, thanks for your comments. Hemi, when you were talking about Medicaid strategies for cost recovery, you mentioned provider taxes. Could you say a little bit more about that?
Yes. So currently under the Medicaid statute, states, and I'm not sure where Georgia is on provider taxes, but states are allowed.
We have one.
You have one. Okay. All right. States are allowed to tax, health plans, for example, other types of providers like hospitals to then use that tax revenue to then help finance what would otherwise be state match for their federal dollars that come in from CMS. So that's what it is, and it's in statute, and there's regulations around that, and there is different ways states have used taxes, some more so than others. It sounds like you have one in Georgia. And so there's a question around, and I think it's this idea around, is the federal government paying more than it should for Medicaid? Because states can use these variety of strategies and not have to put up their direct state revenue dollars in order to get federal match.
Thank you.
So there may be some limits on that, depending on how Congress acts. So in Georgia, we have a hospital bed tax. So it's a tax that comes from our hospitals. It's currently authorized through, I believe, 2030 during our last legislative session. And so that is part of how we bring in enough revenue for our Medicaid program. Well, I want to thank Hemi for all of her expertise and experience, all of the fantastic examples that you brought for us today. Thank you so much for helping us really understand the landscape nationally, federally, and as well as kind of things other states are doing that could help inform what Georgia does. So please help me give a round of applause to Hemi. You guys get to hear from me for just a little bit longer. I hope you've enjoyed the first half of the program. I know for me, one of my favorite ways to learn about what's possible in Georgia is to think about kind of how other states are tackling some of the same challenges and problems that we are seeing here in the state, and that that our leaders and all of us are wanting to address. In addition to flipping the order of our program this year, as well as the time that we normally meet, you may also have found that if you flip your program over, you have a 2025 calendar with you. So I hope you all will enjoy this our little flip theme, our topsy-turvy theme this year. And I hope you'll take your calendar with you at the end of today so that GHF is with you all year long. Before I dig into my remarks, I also just want to recognize some folks in the room. First, I know we will hear from our fantastic legislative panel here in a bit, but if we have our panelists and any other elected officials or state agency officials in the room, if you guys will either raise your hand or stand up so we can recognize you. Thank you all for being here today. I also want to recognize our fantastic squad of volunteers who helped with check-in and getting set up today, as well as our GHF staff, many of whom are sitting here, or Anthony is over here. But they just did a fantastic job planning for today's event, as well as making sure you guys got in the room and got settled smoothly and had a delicious lunch and all of that. I finally want to thank our board of directors, several of whom are sitting here and around the room. So thank you to our board for your role in planning and for all of your guidance and expertise to GHF. And I hope that many of you get a chance to meet several of our board and staff today. I know we've got some new staff members, new faces, and so I hope they get to meet so many of our fantastic partners and stakeholders. And so many of you are here year after year, and we so appreciate those partnerships and relationships. Over the past several months, I have been thinking a lot about change. My husband and I are navigating a lot of change among our close family right now. Some of that has involved a lot of interactions with our healthcare system, some good, some less good. At the same time, as I mentioned, our GHF team has grown and changed pretty substantially over the past 6 months. We, of course, are still here to partner with all of you and to lead policy change that improves the health and well-being of Georgians. But with our bigger team, we've also adopted new practices and ways of working so that we're doing our work more effectively and doing it better for the people of Georgia. And of course, as we're going through all that change, our federal government is in the midst of its own change, its own set of changes, and certainly we will be swimming through those changes over the next several years. So it feels like a particularly a particularly bright season of change in my life, and you may feel like there's a lot of change around you and yours at this time. And as I've been reflecting on change and what it means and my comfort with it, I found that I probably should be more comfortable with change, because as advocates, it's our job to bring change, right? Our work is to identify how things should be different and to bring those ideas and the data and information and the people that would be impacted by those changes, to bring those to leaders and to work with them to effectuate those changes. So we swim in change every day, but we have to identify the right kinds of changes. We don't want to push to make things different just to make things different. The right type of change should be simple, and it should be people-centered. It should really be focused on those who are under-resourced or aren't being treated fairly by a system, and putting those people back at the center of the work. I can think of a number of examples that kind of demonstrate maybe a need for change because things aren't simple or aren't people-focused. We talked a bit about our Medicaid enrollment processes and systems. You know, we saw this in great numbers during the Medicaid redeterminations and renewals period. We saw parents, grandparents, caretakers really frustrated by the Georgia Gateway website and the lack of their ability to be able to get a hold of somebody on the state helpline. We heard from lots of those caregivers, and when they did find help through sisters like Deanna and Melita here at GHF, they were fantastically grateful, really demonstrating the value of having kind of a human-based system. Not to discount that there are good things about automation and technology too, but certainly being able to get a hold of a human when you need them, and having a simple process to kind of walk through and get their problem fixed. Many, once they got their problem fixed, they really expressed they wanted to do something to help and prevent others from feeling the same way they did as they moved through that. In another example, as Georgians, I think we're pretty familiar with seeing our health insurance premiums go up each year. But then when we go and use our health insurance coverage or try to use it, we often encounter paperwork or prior authorization barriers. A doctor recommends this treatment regimen, and our health insurer may say not yet or no altogether at times. And for these and similar headaches, they're so common that in December we saw Americans cheer on a man who violently killed the head of America's largest health insurer. And that was followed by many think pieces, many TikToks, many stories about the myriad ways that our healthcare system is not humane or people-centered or caring in the way that a healthcare system should be. And so this is something that our evolving and changing GHF team is going to be focusing on and working to address. We've always been focused on the voices of Georgia consumers, but we've newly recentered people amidst our own internal changes. We've even adopted a new tagline that you guys have seen on the screen today, whether you know it or not, Healthier Futures Powered by People. And we are really taking very seriously that powered by people part of the tagline. We're reprioritizing efforts to reach and connect personally with more Georgians across the state, and to help them feel empowered to humanize and simplify the systems and policies that we all struggle with, regardless of whether that struggle takes place in Winder or Vidalia or Cedar Grove or Atlanta. You will also see this theme of humanness and simplicity reflected in the policy priorities that GHF has identified going forward for this biennial. We are promoting policies that would not only meaningfully improve people's health, but also help simplify systems and put Georgians back at the center of those systems. Medicaid enrollees really like their Medicaid. 9 out of 10 Medicaid enrollees support Medicaid in its current structure, and they prefer that over a potential block grant or a per capita cap. And even the broader public feels the same way. And so we know that we want to build upon what they like. We want to help keep kids covered more consistently. We want to allow low-income adults to enroll in Medicaid and to make it less difficult for those eligible Georgians to interact with the benefits for which they already qualify. And of course, we see all of that reflected in the stories of people like Paul and Shirthia, who we heard from earlier. The Affordable Care Act and the protections that are embedded in that, like no-cost preventive services and financial assistance to make health insurance more affordable, those get more popular the longer they're in place. And we have put forward in our policy priorities that we want to protect those and put those into state law so that we know Georgians can always rely on that, regardless of what happens at the federal level. Certainly creating a certification for community health workers would help humanize our health coverage and care systems. Georgians would have somebody to walk beside them as they are navigating a confusing system or don't know where to go for a service that they need or just need a little reminder that they need their prescription on time. And certainly ensuring that mental health supports and programs are funded and available widely in communities will help people feel valued and like somebody cares about them. So that is where GHF is focused over the next several years. We will need more ideas, and we will certainly need all of you all's help in helping to lead this change, to connect and support with Georgians. So we are really planning on, going to meet people across the state where they live, hearing their stories, and making sure their stories are heard by both the people in this room and also our leaders across the street, as well as in state agencies as big decisions are being made about the policies and programs that impact their lives every day. We are planning to build and connect with the broadest constituency we can possibly manage across geography and politics and incomes and health statuses. We know that it's really important, especially as a nonpartisan institution, to demonstrate that there is broad support for these policies, and we know that there is. These are things that Georgians believe in and want for themselves and their communities. Finally, I wanted to share a quote from one of my favorite books, Parable of the Sower by Octavia Butler. For those who have like a reading New Year's resolution, put this book on your list. It is fantastic. The quote is that all you touch, you change. All that you change changes you. And the only lasting truth is change. This quote brings me a lot of comfort in seasons like this one, in seasons of change. And maybe in seasons of your own change, you'll think back to it as well. It reminds me that we're always in the midst of change. So this season isn't actually all that different. Maybe it's just more apparent and it's more specific right now. But it's always with us, and we have a little agency over it. We don't have full control over the change that we're going through, but we certainly have some impact on it. And in the context of advocacy, it also reminds me that while we are working to reshape systems and policies and improve the health of our state, that just by doing that work, we are changed, hopefully improved. Hopefully it pushes us as individuals to be more people-focused, more to look for simple solutions, to really be the leaders and the advocates that we want to see in the world. And at the same time, maybe it's a type of warning that if changes move our society or our structures or our health system to be more unfair or harder to navigate or more expensive or less accessible, that maybe that also rubs off on us too. For myself, I don't want to feel or be those things, and so I will be looking out for policies and proposals that move us in that direction and be defending against those while also working for the changes that will move us and our systems and myself in more positive and productive directions. I know that I and GHF can count on so many of you guys to be with us during all of these changes and to work for those changes, and that you believe in many of the same things that we do, that people deserve affordable, quality health care, that should happen in their communities from people who respect and value them as individuals. And we certainly look forward to working and changing and partnering with all of you and thousands of Georgians across the state during this legislative session and throughout 2025. So thank you for being here this morning, and thank you so much for all of your partnership and support.
Please welcome to the stage Whitney Griggs.
I'm Whitney Griggs. I'm the Director of Health Policy with Georgians for a Healthy Future. And I have the wonderful opportunity today to lead our legislative panel discussion. We have a wonderful group of legislators with us this morning. So we will spend a little bit of time talking to them, and then we will open up questions to the audience. You all have note cards on your table. So if a question pops into your head while we're having our discussion, please feel free to write it down, and my beautiful assistant, Andy Lord, will come around and pick up questions, and we'll try to get as many of them as possible. So if I could invite our legislators to join us up on stage, and we'll do just some quick introductions. I think most of you all know who they are, but we'll go in order as they get on stage. So we have Chairwoman Darlene Taylor from Thomasville, Georgia. Representative Taylor is the chairwoman of both the Appropriations Health Subcommittee and the House Insurance Health Subcommittee. We have Chairman Lee Hawkins, who is from Gainesville, Georgia, and he is the chair of the House Health Committee. And we have Senator Kim Jackson, who is from Stone Mountain, on the Senate HHS Committee, and also works at the Episcopal Church of the Common Ground in downtown Atlanta, where she works a lot with unhoused individuals in the city and has a lot of experience in that. So looking forward to a great discussion, and I will not turn my back to Steve all because that's a little weird. So to get us started, we just had a wonderful conversation with Hemi and Laura about, there's a lot of change happening right now, and no matter what administration it is, when a new administration comes in, that can create a little bit of uncertainty. So we'd love to start out the conversation with just one, what are your priorities for this legislative session, and then follow up with that of how do you kind of prepare for those uncertainties as much as you can. But to get us started, what do you see as the most pressing priorities for health policy this session? And we'll start it off with Chairman Hawkins, since you're closest to me.
Well, thank you very much. We'll be looking at a number of things this session. Delivery of health care is always at the top of our list, right beside the financial impact of health care. We seem like we're always running behind the cost of health care. The CPI on medical health care is always higher than the average inflation rate. That affects our providers, which then affects the patients. We all want access to quality care for all Georgians, and we work toward that in the different silos of health care, whether that be Medicaid or Peach Care, Medicare, or state programs through DCH, state health benefits. We've got about 2 million people in Medicaid, Georgians that are registered in Medicaid right now, over 2 million. Large number to manage. I think DCH does a very good job with the manpower they have. I think we've been very frugal on the state side with our state government size. I've always said that, but then again, when you look at the budget, everybody's got a tough place in that budget. Healthcare is about 23% of our entire budget, with education being about 54%. So you're looking at 80% in two silos. And as you see, the governor now this year is trying to bolster up our prison system with over $660 million, which is needed, but obviously we need funding in every direction we go. So we'll have eyes open and everybody ready to go on a number of the healthcare issues.
We can just pass it down the road for this one.
Okay. We all are aware there are delivery. I think one of the issues that we are addressing and will continue this year is the shortage of providers. This has hit every community. Our doctors are retiring and we can't get them out of medical school fast enough. So we have invested quite a lot of money from the state level to our medical schools and our residency program. I think we will continue that and actually try to beef it up a little bit so we can get them out sooner. There are other specialties that we need, and psychiatric is one of them. Another thing that we have done is help with some of the licensing. Licensing is a tough issue, getting it through the process, and we're trying to streamline that. I anticipate some improvements in that area. One of the things we've done over the last couple of years, and I plan to continue this year, is to try to upgrade the reimbursements for Medicaid providers. They are too low. Using OB as an answer, you can't do enough hysterectomies to pay for the babies that they're being reimbursed at less than half what it costs to deliver them. So I think we need to look at the use of community health care workers also. That's a new area and a new idea I think that could be beneficial. I think one of the other things as I look at the big picture, and it has to do with both the providers and being able to make sure that they stay in Georgia once they graduate. Georgia has made a significant investment in the area of medical education in both brick and mortar and quality of staffing. And I have a saying that I've shared several times. If you build it, they will come. But if you don't pay them, they ain't staying.
That's a good one.
We have to address that, and I think I've made that point to some of our leadership, and they are recognizing it, and I hope to continue that this year.
First, thank you all so much for being here, and thank you for having me. If you look at the list, it says Harold Jones is here. I am not Harold Jones, but I wore a vest in honor of Harold Jones. I want to talk a few things that I think are real priorities for all of us here in this room, and for the legislature in general. One is the provider shortage. There are simply not enough doctors, and there's not enough doctors in the right places. And so we have a bipartisan bill that I'm actually sponsoring in the Senate, but has very strong bipartisan support that will help address that by taking physicians that we already have living in our state and creating a pathway for them to get licensed. I happen to represent Clarkston, Georgia, which is an incredibly beautiful town that has over 80 languages spoken in that city. And I have physicians right now today who are driving DoorDash, people who worked in their country, who perhaps even cared for our soldiers, who are not able to get licensed right now because we don't have a pathway. And so I'm really proud of this bill. I'm really grateful Senator Kirkpatrick is helping me carry this bill so that we can create a pathline to get those folks off of DoorDash and into our hospitals. And so that's one of the ways that we're really committed in trying to address this shortage. I think another thing that we have to continue to be very aware of, and I think it's at the forefront of many Georgians as it relates to health care access, is mental health care access. If you've ever had particularly a child who is in need of services for mental health, whether you live in Metro Atlanta in the most densely populated areas, or if you live down in Good Valdosta or somewhere in between, the likelihood of you being able to find a person to care for your child, your youth, is extraordinarily low. And so we have to continue to provide incentives to get more people into the field. And I echo my colleague here, reimbursements just have to increase. There's no real, it's not just dollars and cents, right? If you have a person who goes through the training to become a physician or to become a psychologist, psychiatrist, a counselor, and if they can't pay their bills because the reimbursement rates are so low, they're just going to only take private patients because they're trying to pay their bills. And so we really have to address that issue and take it head on. I really encourage folks to not just to do this work of getting the education in order to provide mental health care, but then to make sure that we have funds to pay them adequately. And then finally, my caucus will remain committed and always will continue to push for further expansion of medical coverage for Georgians. We will not stop beating that down and saying over and over again, we must increase coverage. Right now today, there are over 500,000 Georgians who do not have access to health care. We're ranked number 48 in the nation when it comes to access to health care insurance. And so it is absolutely essential that we continue the work to expand coverage for all Georgians so that we don't have folks incurring incredible costs from emergency services or just not going to the doctor at all, and therefore getting very, very sick.
Thank you. Thank you all for such thoughtful answers. And without, delving too far into what's possibly on the horizon with the federal landscape, I think it is worth noting that there's a lot of uncertainty right now, and it can be difficult to set legislative priorities in the state when a lot of the policies that we're able to pass here are, dictated by what's happening at the federal level. Medicaid reimbursement rates depend on how much money do we have for our Medicaid program, which is very dependent on the federal government. Thinking about these really, thoughtful answers that you all gave, how do you operate with decision-making, policy-making, prioritization amid the uncertainty in the federal landscape and ensuring that Georgians do have access to affordable health coverage, that we are paying doctors, mental health providers somewhere closer to what they should be paid? How do you approach that during your legislative sessions?
Well, that's something I've always spoke to since I've been in the legislature, and actually before. I'm a retired dentist, but when I entered the legislature, I was still running a dental practice, and I can tell you that the way I handled Medicaid was I volunteered at public health and let them actually apply for the Medicaid reimbursement and use it in their office. I was a small office with one lady up front and an assistant and a hygienist when I started, and the lady up front, who is still in our office 45 years later, came to me and said, if you continue to take Medicaid, I quit. I just cannot fill the paperwork out over and over again. They keep sending it back, and each company is different. We don't have a standardized form. So that costs the offices a lot of time and effort. That's something that I've worked on over the years, and hopefully we'll be able to get that enacted. It would be a savings for our state and for our providers, and expand some of the Medicaid right there. I've always spoken to the Medicaid rates. They are very low. I remember we were down visiting in Thomasville at Chairman Taylor's hospital, Archibald. The OBGYNs down there told us that they were paid $1,200 for all the prenatal, delivery, and postnatal care, post-delivery care. And I said, gee, that's the cost of an iPhone. So, we've got that barrier. But when you talk about federal funding, our total funding is about $7.3 billion in the state funds, and our FMAP's about 34%. That's the federal matching. So if you take the 7.4 and then double that, Medicaid is 4.6 of that. So if you take that and double it and add, we got about $13 billion that we're running through there. And that's a lot of money, but at the same time, health care is expensive. We've got a lot of folks that we cover. I think we could be more efficient than we are, and we're always working toward that end for efficiency. But my colleagues are completely right about the young folks coming out of medical school and dental school. They're coming out with a debt over $260,000. So a young dentist would borrow another $240 to set up 3-room practice. Buy maybe a double wide for another $120. So pretty soon she is $750,000 in debt. They can't pay that on Medicaid reimbursement, and their numbers are pretty high there in the middle of South Georgia. So I applaud the governor's office. He has increased in a number of areas our budget. We increased mental health, another $26 million just in the last budget from last year. And but it's still, we're still catching up, and I can guarantee that we do depend on those federal funds, and we're very interested in what the new administration is going to do, and very anxious to see that they uphold what they've said. The federal government has promised to take care of health care. I'm going to hold them to that promise. Thank you.
I think we all know there is actually no way to predict what Congress is going to do, ever. It's anyone's guess. We don't know, and I wish we did. I wish I had a crystal ball that would tell me. But my thoughts are that we need to look at some of these issues because we're going to have to address them, whatever they do with it. So it is important that we do. I will tell you, I watch very closely what's happening in the courts. There is a Supreme Court case right now that is under review that has to do with the preventive services. And I am a payer, I'll confess right now, but it's something you need to understand, and it affects both the physicians or the providers and the patient. You really need preventive care. That is the key to a healthy population. And an ounce of prevention is worth a pound of cure. We all know that. We've heard it all our lives. It's something we do need to watch, and I'm very hopeful that will stand and it will still be there. I will tell you, my groups that I did before it was ever in the ACA, my clients did it. It was just good common sense. So I don't understand why anybody would want to do away with it. It's something we're going to have to address. But we do all have to be prepared for any shifts. And how do we do that? I will tell you, I'm a constant reader. I have got to stay up on what's going on. Without that, I read all kinds of periodicals and publications. You just have to. You do it in your industry, and it's something we need to do. I do continually watch the courts because they're sneaking through in other states, and they can become applicable to us. There are solutions, and the state is addressing them. We're looking at them now. But one of the things I do, and I think every one of you can do also, is I contact my congressman. That's where these things are happening, and I think it is a time for us to make sure they know where we stand on these issues. I'm not going to hold my breath with what they're going to do, but I'm going to be available and ready when they make those decisions.
Thank you, Chairwoman Taylor, for mentioning the preventive services issue too. For those that aren't familiar, we do have a fact sheet on the table as you're leaving, but she was referring to the Braidwood case, which challenges the ACA's no-cost preventive services. And the Supreme Court agreed on Friday to take up the case this summer, so we could potentially have a big shift in whether or not preventive services are covered. And some states do already require the insurers cover preventive services. And then also we could see this summer the expiration of the enhanced premium tax credits. If this all sounds like Greek, there are fact sheets on the table, and you'll be hearing more from us about that. But thank you so much for teeing that up for us. So getting down into the details a little bit more, if the AV folks could bring up the behavioral health slide. I want to talk a little bit, hopefully everyone can read that, about Georgia's investments in mental health and substance use treatment. We talk about what a challenge mental health care is, not only in Georgia, but nationally. It's a sticking point for all states, as Hemi mentioned. And the Georgia legislature has done a lot to invest in programs or policies to address mental health, whether that's APEX, which Laura discussed earlier, or the Mental Health Parity Act, which was passed in 2022. We do have some programs and policies in place to support access to care, but we continue to rank at the bottom for access to mental health care and for mental health outcomes. So I'd love for you guys to talk a little bit about how can the legislature ensure that these existing policies and programs, the great work you've already done, are effectively implemented and enforced, and then what else might be necessary to address access to behavioral health care in the state beyond what's already happened. And Senator Jackson, I'm going to let you kick it off.
Yeah, thank you. So I want to begin by just acknowledging and really applauding the work. Really, it was led by the House to really dig in deeply on issues of mental health care. The late Speaker Ralston was deeply dedicated and committed, and it's been really great, I think, to have mental health care lifted up and in many ways destigmatized as a result of the work that the House has led on. And I will acknowledge and honor that the governor has put in some additional money to continue to improve access to mental health services in schools. But here's the fact, it's not enough. It's just not enough. I mean, it's like if you're trying to build a house and, you know, it's great that your mother gave you $10 to go towards the down payment on the house. That's real good, but the hole is so deep that the $10 just doesn't get you there. And the fact is, that's where we started. We started in a really, really deep hole. And there's a couple of factors, right? So it's access, not having the providers. It's the cost in terms of reimbursements. It's also fundamentally, we still live in a place where there's stigma around getting mental health care services in the first place. And then there's the lack of funding. And so as we move forward, I think the legislator has to remain committed to continuing to pour real dollars, real money, real investment to getting us out of the hole, just to get us up to par before we can even talk about what it's like to live in the state where we are great at mental health care delivery. So I think that's one piece. And then the other side of it, I think, is up to all of us. We do have to do the work to destigmatize mental health care. People need access to care in the same ways that I go to the doctor to treat diabetes. I go to a therapist to make sure that I stay well in my head, right? Like, those things are really important, and that's the work that all of us can do. Is to help begin to destigmatize it and to say, yes, we're going to invest in this because this matters for every Georgian, not just a few Georgians, but for every Georgian.
All right. You know, this has always been a target for us, and our First Lady, Marty Kemp, has done a wonderful job the last 6 years promoting better mental health and mental health care in our school system. We've actually doubled the budget for DHBD since 2010, but we still got a long way to go. You know, we're still behind on the money aspect. We had a pretty good system back in the early 2000s where we had regional hospitals. Georgia being one of the largest states, the largest state east of the Mississippi, and a lot of it rural area, we found it difficult to have enough mental health experts, not only in schools but in our clinics. So we had these regional hospitals. Well, the federal government told us we had to shut those down. In their wisdom, they felt like we ought to be like New Jersey. Well, our towns don't touch each other. And so that idea has really put us behind. We're still struggling. You know, our community hospitals struggle, and to expect them to have a full department and be able to treat anyone and in their schools is not a good approach. But we have built back and will continue to build back. We're encouraging students to go into that profession with scholarships, and we're looking toward the Georgia psychiatrist to be able to help us more in Medicaid. I spoke to them a few years ago, and one psychiatrist in the room actually saw Medicaid patients. Only one. And that was because the reimbursement is so low. And these folks, men and women, do a wonderful job. Believe me. I mean, they're seeing patients, and they don't even charge them. So although some of them are not taking Medicaid patients, they are seeing people at no charge. So, but we can't expect a healthcare system to run on that type of payment system. So, you know, I'm sure in the budget this year, and the lady sitting next to me is chairman of healthcare budget, I'm sure that Darlene's going to fix it. So thank you.
No pressure.
Let me just open my wallet. This is a very personal issue for me. I was in one of those communities, and I will tell you, we had the best state mental hospital in the state. It was second to none. And we are still dealing with the issues from that. The OMSED Act hurt people. It did not help them. It's a heavy burden for any community. And today I see most, and this is probably not a fair, but too much of our mental health care is done in our prisons and jails. And that has got to stop. It cannot be. That's not where it should be done. It should be done where the patients are and where they can get the right kind of care that they need. The facilities that we had were wonderful. I will tell you, every hospital was not but this one was, and there was no reason for it to have been shut, I don't think. The group homes filled some of the needs, but I don't think it's as good because I don't think you can check on patients as easily. There were so many things about that. And again, 12 years later, we don't have a better life for those people. We do not. The state will continue to work with the caregivers and the homes that are out there, but our hands are tied with having the large facilities. I used to volunteer at ours, and it was rewarding to be there and to be of help and to see what was happening and changing lives, and that's gone now. But I can't cry over spilt milk. We've got to go forward, and the big issue we're dealing with right now is providers. It goes back to those providers again, and if we don't pay them, we're not going to keep them. But there are things we can do, and we're looking at the licensing issues to speed that up. And again, in psychiatric, particularly in the underserved area, which quite frankly is the entire state, we need to have those scholarships or help paying off their student loans when they go into their practice, if they will practice in those areas. And I look for us to go forward with those kind of options for them. Thank you.
Great, thank you. And just a testament to the caliber of our panelists. We're, hitting on some pretty heavy questions. We started out pretty high level, but we very quickly got into how are you going to solve the mental health crisis? And now we're going to ask, how are you going to solve the housing crisis, which is an issue for all states? And even deeper, how are you going to solve the housing crisis for people with mental health needs? But, Chairwoman Taylor, you mentioned the Olmstead decision. Some of you all know that Georgia is currently under a settlement with the Department of Justice about how we treat people with serious mental health needs. And regardless of how we treat folks, access to housing is incredibly important, especially for these folks who are caught in this cycle of being unhoused, having an interaction with law enforcement, ending up in the emergency room, ending right back up on the street. That cycle can be unending unless you intentionally stop it. And one of the programs that Georgia does have in place is the Georgia Housing Voucher Program, which is a housing voucher operated by the Department of Behavioral Health and Developmental Disabilities. Thank you, AV. That for people with the very specific diagnosis of serious and persistent mental illness. So my question is, how can, or what legislative opportunities do you see to both, increase access to the housing voucher program for people who need it? And how can the state more broadly address the housing needs for vulnerable populations, because health and housing are so deeply intertwined? And I don't know if Senator Jackson would like me to start with her again, but I'm going to.
Sure. So this is the work that I do when I'm not in the legislature. I work with people who are experiencing homelessness or who have experienced homelessness. And I can now say that in past tense, have experienced homelessness because of the Georgia Housing Voucher Program. A number of my parishioners now are housed and are stable as a result of being able to be one of the lucky 2,000 people or so who were able to get a voucher. The problem is we don't fund the voucher to the level that it needs to be funded. We do not have enough vouchers for folks. So while we have plenty of people who qualify, some of whom you may have literally walked by today as you came in here, they're qualified. Many of them have actually been gone through the program, the process to sign up for it, but we ran out of money to fund it. And so I think it needs to be a high priority for us is to fund that voucher so we have more vouchers to give to folks. And then let me be clear, the program works. When people who have serious intractable mental illness receive housing and wraparound supports, they stop going to jail, they stop going to the emergency rooms, they stop standing in the middle of the street and causing accidents or getting hurt themselves, and they get preventative care for basic things like diabetes, heart disease, the things that we all have. It works. I've seen it firsthand time and time and time again. And so it's actually worth the investment. It's worth the investment on the front end because it does save us so much on the back end. The way I explain this program to folks who, I'm a pastor, right? I'm a preacher. So I go to churches to explain to them that they need to give money to our church so that we can help people get these vouchers. The way I explain it is that in the same way that as I'm an aging person, and at some point I may age to the place where I will need to live in assisted living. And then as I continue to age, perhaps I might experience some more decline, and I might need to go from one level of care to another level of care to another level of care. This is what we do for our loved ones, right? You know, as you have a loved one who ages, you put them in a place that can provide them with the supports that they need as they continue to need those supports. That's what the Georgia Housing Voucher Program has done. It's taken folks who have these significant illnesses, who have significant problems, put them in a house, given them the support to meet the level of need that they have. And then something miraculously happens. When people get the services that they need, oftentimes their level of care decreases because they no longer need as much care because they're getting their medications, they're stable, they have community. And so I am a huge promoter of this program. I think that it is where our dollars need to go if we actually want to address this issue. Housing first matters, but housing first with supports is what actually saves lives.
The housing needs across the state are different in every community. I represent a rural community, and until recent, it was like, we don't have a housing shortage in my community. Yeah, we do. And it has shown, and it is growing. I think it's everywhere. And at first it was hard for people to acknowledge it. It is there, and funding is a big part of the ticket. How do we do it? I'm sure a big portion of this are those with a mental illness. You would not want to live on the street. You would like to have that care, and they need, I think, another item that will help would be our community healthcare workers, those that would be making the rounds. And I've seen a couple test pilots where they have used the EMTs, where they have an offshoot of them going and making the rounds, and the hospitals complain about the frequent flyers, the people that come, they're off their meds. This is a way to help cure that. But the housing is a big part of it. We must have a secure for them. Where we're going to get all the housing right now, it's not just money. It's houses themselves. There are not enough facilities, and part of that has to do with what the economy has done statewide, countrywide. There's been a recession. I don't know that they would call it officially, but there were not people making investments in things like that. So it has been a burden for us, and we are still trying to make those situations better. We will continue to work with the caregivers in the homes that are out there. Rent subsidies and support for a number of these private nonprofits will continue. We'll look and see where we can best spend the money. You're hearing all the needs that we have. That pie is only so big. So do we take it from schools? Do we take it from teachers? No. We've got to find resources to be able to spread those dollars around.
You know, over the years, we've looked at this, and being from Gainesville, I've had a great opportunity in the community that I live in because it's such a giving community. We have Randy's house and Rachel's house, which are for the disabled and the developmentally disabled. Our Kiwanis Club has built homes for battered women. We have the Good News Clinic where we volunteer, the largest clinic in the state, medical and dental, but also the other side of that is providing food and shelter for those that are in need. I think that in the future we should look more toward community development in these areas and funding more from the federal to the state, but then going to the community. We find it pretty hard to try to do it from Atlanta, just like Washington finds it impossible to do it from Washington. So I'm a big believer in moving things to the community, and that would be funding also. I think that is the way for us to approach a lot of these problems in the future, is for local. I was approached today about helping the Ben Massell Clinic. They lost their local funding for this year. Ben Massell is a dental clinic that when I was in dental school, we all volunteered, and after we left dental school, graduated, we volunteered. It's downtown Atlanta. It's been there for 100 years, and they just lost their community funding. Well, this would be a good example of us being able to shore up that through the state or federal, but do it through the community. Communities know what they need. They know where they need it, and they know how to do it. And it's more personable. So I think that's much more of a successful way to approach this.
Yeah, absolutely. So I'm going to mix it up a little bit just because we're running short on time and combine a couple of questions. We've talked about some of the challenges that potentially coming down the pike to affordable health care, including the EPTC expiration and the access to preventive health services. Georgia, as we mentioned, as Sarah Jackson mentioned earlier, ranks 48th for health insurance coverage. We have I think we're tied for second for the highest uninsured rate in the country. And I think we have about 16% uninsured adults and about 6% uninsured children. There's some things that the state can do to address, access to health insurance, and some of those challenges are federal. What steps do you think that the legislature can take to both reduce the number of uninsured children and adults that we currently have and prevent any further coverage losses considering the potential challenges? And also thinking too about Georgia Access, which is the new state-based marketplace who has over 1.5 million enrollees as of January 8th, which is a huge, huge success. How are you all thinking about not just growing or lessening the number of uninsured, but also preventing any coverage losses?
Since I do insurance, I'll start with that one. This is our uninsured numbers, they're moving and they have improved a lot. We still have a ways to go, and we all understand that. One of the things I will tell you that I have a concern, and I don't know, you may get to it, is the enhanced premium tax. That's out there in the Netherlands. I don't really want to address it, but it's in there. We've got to pay attention to it. We're going to watch it and make adjustments as they are. Leadership does know about it. We're aware of it, and just keeping an eye on it. But this year, I will tell you, the DCH had a full review of their bid process. Everybody was aware of that. And in my job as a legislator, I hear from my constituents when there are issues. And sometimes I could get good help, and most of the time I did. I shouldn't have to be the one to fix it, but a lot of times I had that backdoor number and I could get something done. We all see that every day. But I do feel like this process is going to change things. You talked about change. This is a major change, and it's a big concern that I have, that we're going to have continuity of care and continuation of coverage, and the eligibility processing is being reviewed, and it needs to be much more streamlined. That is something I think we're all addressing. There's no silver bullet. We know that there's not. It will take all of our efforts, and it will be don't want to predict it as difficult. It's just going to be change. Nobody likes change, a different number, a different process. But information needs to get into the hands of the right people. I find a lot of times they just don't have the right information or contact. No matter what it is, that's the most important thing we need to do. We may get to it, but one of the things that we're using right now, and it's helping us to make decisions, I've just started getting it, is information from the all-payer data claims. I think that's going to be a tremendous asset for us, and that is going to help us direct how benefits are paid, a lot of things that we can do with that.
The only thing I want to add in terms of making sure that children remain covered is I really think that we need to advocate for a 0 to 6 enrollment period. So you give birth to a baby, the child gets Medicaid, you qualify then. I think you should qualify before you leave the hospital or before the doula leaves the room. That paperwork needs to be done. And then 0 to 6. Why are we kicking kids off Medicaid? And, if it happens that their parents' circumstances change and they're no longer eligible and they get private health insurance, then great, that'll be the primary health insurance. And we carry on. Like, there's no really good reason to kick our kids off. And so I really want to push for us to just go ahead, log them in, and let them roll until they go and enroll in first grade. And then we can have some more conversations about whether or not you continue to qualify or not.
You know, we're sort of hamstrung, not sort of, we are hamstrung by the federal requirements. You know, when you have to re-sign for Medicaid, that was actually came from the feds. That we didn't think that up. Unfortunately, we were not prepared for the large numbers that we had in DCH, struggled with the manpower to do that, and also the people figuring out how to contact Medicaid. A part of our situation is the flow of information to the public, and then the public being able to react to that. Who do they call? You know, they may not have a laptop at their home, so then they're doing this by phone call, you know, and frankly, we don't have enough folks to answer those phone calls. I mean, I think the Department of Labor sure indicated that to us when we went through COVID. So DCH still struggles with that, but their DCH is being run by a great commissioner. I've known Russell for, God, I don't know, 20 years. He does a great job. He's got a great team there. They're making improvements every day. So I see a brighter future for all Georgians, and those that are signing up on the Medicaid rolls. I think we'll see an improvement in that. And so instead of looking at the negative side, I always try to look at the positive side, because there is one. And with your help, we'll get there. Thank you.
Thank you. Well, I'll close out with one last question. I could stay all day and ask you all questions. And I'm so glad that you mentioned that you're using the all-payer claims database, because all of the health policy nerds in here are very excited about this. And I really want to thank Chairman Hawkins for the legislation that created the APCD as a part of the surprise billing law. I think we have a slide on the APCD. For those who are not familiar, APCD stands for All Payer Claims Database, and this is a centralized data repository that has claims data for both public and private health insurance. So researchers, policymakers are able to go in and get all sorts of de-identified data that we were never able to have before. The website has a public-facing dashboard, so if you're just interested in some data, you can go in and look, and you can also make requests for private data too. And they just started taking requests, I think, back in October, so it's very exciting. Chairwoman Taylor told us a little bit about how she's going to use it, but Chairman Hawkins will let you answer the last question, since you created since you're responsible for the legislation. Any thoughts about how you might use, or your colleagues might be able to use, the APCD to improve some more evidence-based policymaking?
Yeah, thank you. You know, as providers, in the past, we were continually facing decreased payments from the insurers. Our payments actually started decreasing in 2017, and they used a database that they actually owned. So there was very little argument involved. We did the work, and they paid us what they wanted to pay. Well, with the All Payers database, this will be based on the fees being charged rather than the fees being paid. And that will help right the ship with some of the payments. You know, when you're a provider, you've got folks that are paying, you've got insurance folks, and then you've got folks that have nothing. And if you have a better payer mix, you can do more to help the folks that don't have anything, or take more Medicaid patients, or take more Medicare patients. So one of the ways to face this reality is with this All Payers database. Like I said before, the medical CPI is about double of what inflation is. And that is, we have newer techniques, we got newer equipment, and it's very, very expensive. I mean, in our dental practice, we looked at a CBCT, that's a cone beam CAT scan for the dental office, so we could actually do a lot better treating, especially abscesses and different things like that. 5 years ago, it was like $260,000. So, for us to be able to move forward and provide better care and care in a more timely manner, then we need to be able to be reimbursed on a fair level playing field.
Great. Thank you. I just want to add, this is probably one of the most exciting things for me. I'm a numbers wonk. I want to be able to spread it on a spreadsheet. And so I'm very optimistic about it. And this information will help us all make better decisions. We'll have better information to make those decisions. I expect to see all kinds of things, diagnoses, service areas. One of the things I think that's going to be important is going to be cluster diagnoses, different areas where we're going to identify problems. I'm just telling you now, it'll be out there. Kidney failures, premature births, things like that we will see by location. Also, we're going to be seeing where there's a lack of service and how many service providers there are in different areas. Our urban, rural, and our suburb areas are now suffering too. So prescription drug costs and the 340B programs, all of these are going to be helped with this data. So I'm excited as can be about it. Thank you.
I think that excitement is contagious. Hopefully your colleagues will feel that too, but it really is a great opportunity for Georgia. And so we are now, awesome. So we're gonna open it up for questions now. So just a reminder, if you have a question for our legislative panel, you should have note cards that look like this on your table. Please feel free to pass them around and you can hold them up if you'd like Andy to grab them from you. So we'll start off with the first question. The Pathways program, Pathways refers to Pathways to Coverage, which is Georgia's partial Medicaid expansion up to 100% of the federal poverty level with a requirement for qualifying activities. It is still only has about 5,000 enrollees. Do you think this program should continue? Why or why not? How could we get more Georgians covered?
Yeah, I'll start. We're aware of my political affiliation. The program is broken. It's not working. When you only have 5,000 people enrolled in a program where we know that there are a whole lot more who are eligible, it's broken. But I acknowledge that it exists, and we have it. So since we're going to have it, and we're going to have it for a little while, we need to be getting people enrolled. And we really need to work with folks to help them see the ways that they can become eligible. I was just saying, so I have this church that I run, and I have these very faithful volunteers who do what I would never have called it community service, because it's just, it's church, but it's community service. And so I'm just like, how many other places are having folks who are coming in and volunteering and doing community service, which could be a qualifying piece for them, but they're not, we're not saying, oh, why don't you enroll and we'll make sure you get your paperwork for your credits. We need to start doing things like that, because the program is here. It's going to be around for a little while. So I really hope we just do the work. We need to invest some dollars to continue to advertise the program in the first place. I do think enrolling is kind of complicated, so maybe we could streamline that paperwork too. But fundamentally, I do think it's time for us to think really creatively about how we encourage people to enroll, who can qualify, who may not have thought that they would qualify in the first place.
A question in a similar vein, unless someone else wants to answer the Pathways question. If the federal match for Medicaid is reduced, what happens to the conversation on Medicaid expansion, especially as Pathways nears its expiration, and I will ad-lib / renewal date. So the Pathways waiver ends this year and the state will need to renew it.
Well, if that AFMET changes, that's going to put a major implication on our budget. It's pretty hard to tell someone you're not going to take care of them when you have been, and you really can't do that. So hopefully the incoming administration will be able to find a way and see the light and go ahead and keep that FMAP. I would like to see them improve it. I think it will really help our state budget to be able to expand into more of the mental health areas and especially move that into the schools a little bit deeper than we have already. Like Darlene said, we never can guess what the feds are going to do. We just sort of react to them. Most of these programs are slated or they sunset in 2025, some of the tax programs. So we've got a little bit of time, but unfortunately our budget that we will pass is the 26 budget, which will start in July. So we have to be very prepared for any change they may make. We don't borrow money on the state side. We pay for everything we have. We're a balanced budget state, so we can't Forrest Gump our way through these things, although it appears that we do a lot of times, but we don't. So, maybe we ought to have this conversation another 2 or 3 months, see what they're doing.
Yeah, I think that's a fair answer, and I also would not want to answer that question either. There's a lot of prognosticating that's very difficult to do in the moment. And since we're on this thread of changes on the federal level, I'm gonna take the opportunity to circle back on a topic that Chairwoman, you've brought up a few times, which is the expiration of the enhanced premium tax credits, which we do have a slide on, but weren't quite able to get to in the questions. So a little bit of background. During COVID, Congress passed additional tax credits to help lower the cost of health insurance for people who were buying individual health insurance on the marketplace. Though that enhanced tax credit is responsible for the huge enrollment numbers that we've seen in Georgia and nationally, it is a lot of folks are paying $0 for their health insurance. Those tax credits expire this year if Congress doesn't act. And as we are talking about, is very difficult to know what's going to happen at the federal level. But that could be a huge shift in the healthcare landscape. So would love to just hear from you all how you're thinking about how can the state prepare for potential changes, recognizing that insurers certify their rates in the summer. So even if Congress addresses this in December of this year, that'll be a little bit late. And really, what is the role of the state to help manage that?
That's a good question. What are we doing? We will, right now, leadership is looking at it to find out what we can do. I will tell you once again, Georgia's in a better place than many states because we didn't make an expansion that we cannot now meet. If I was a betting person, I would bet we're going to get an extension on our pathways. I think that will be extended. I can't even begin to figure out what they're going to do with the enhanced premium. It's a new administration. It's tough every congressional year. But it's extremely hard now when you have new leadership in the White House and you don't know what the priorities are yet. So it's going to be very tough. I think that we will have to set aside some money just to make sure, but we can't set it aside and not use it when we have other needs. That's the problem. Do we hold it in a reserve? I know we need to do it, but I also know there's needs that need to be met right now. So we are looking at those things right now. It will be a decision made very thoughtfully, and it will be that'll be probably the hardest decision I make this year.
Thank you, and I'll just, our panelists really did their homework with these really thoughtful answers. I know that we've been talking about it as well, Chairman, so I don't know if you've got anything you'd like to add.
Well, it's hard for me to believe that Congress is going to go home this summer and face their constituents and say, guess what I did? This does have a large impact on the cost of health care for those that are in middle and lower incomes that are now spending what they did save of that 40% that reductions they saw in the last couple of years. They're spending that on food and housing now. So that money's probably not available to them. So this would mean the difference of having some type of health insurance or no insurance. if I was a Republican congressman or a Democrat congressman, I wouldn't want to go home and tell somebody I did that. You know, I didn't tell my mother all the things I did. I sure wouldn't do that. And that's not, you know, that's a joke, but at the same time, it's not being it's not having a human outlook on what we do and what we're responsible to do for the public. So I assume they will not do this, or they may reduce it. There may be somewhere in between rather than all or nothing. You know, the state did not hold this up before. This would be new funding for us. It would be continual funding, and it'd be very, very expensive funding. I don't know how we would be able to handle that. You know, we're focused on the pathways. We're going to build that. The access has been very popular. You know, from 100 to 150%. There's no payment for that. There's no premium. I mean, and so we're going to focus on the things that we've got and make them better, and in spite of the federal government.
So taking a little bit of a different tack now, we've talked about mental health, housing, thinking about the big sticky challenges that the state faces, moving on to maternal mortality. In what ways do you believe the state legislature can address the state's maternal mortality rate, especially among Black women and people in rural areas who are disproportionately affected?
I will tell you that has been on our radar for quite a while. We've had a study committee. I was on a study committee about it, and it's very personal to me. I never knew my maternal grandmother because she died in childbirth. And I think that in this day and age, I mean, that was 100 years ago or whatever. Today, though, it shouldn't be happening, and what can we do about it? The state has taken it very seriously. We've extended coverage for a new mother for 12 months, which I think will be very helpful both before and after. We need mothers to stay healthy, be healthy before you get pregnant. A lot of this is getting information out to the public, whether we do it through our health departments locally. I'm not sure what the best way to do it, but it's information again, getting it to people. A woman needs to know if you're pregnant, you're covered, you got Medicaid, let's go get treatment. I will tell you other things that we have done, but one of the things that we put in the budget last year is a new test that just came out, and it was to predict preeclampsia, and it is 99% effective on Black women. They will tell you if you're going to have an episode within 10 days, 96% in white women. The problem is word has to get out to the physicians to do the test. You need to show some symptoms. You can't just carte blanche run the test on everybody. But if you're symptomatic, you can get that test done, and within minutes you'll know, maybe not minutes, but shortly you will know whether or not. So it is something we're taking very seriously, and I think we need to have more education to the public, and there's many ways to do it. I think our FQHCs are doing a good job reaching out. I will tell you, I was visiting one of my FQHCs at home, and while I was there, a woman called. She said, I'm 8 months pregnant. I think I better come see somebody. There's no excuse for that. You know, there's no excuse. You need to be under care. Anybody we know, we need to find places, whether it's in your churches, in schools, in colleges. We need to make sure that this information is posted, that you have care. A woman should never think she has no coverage.
Yeah, I will echo that the legislature has been trying to address this kind of in a piecemeal fashion in ways that I think are really important. We spend a lot of time and energy and dollars now in investing on lower income women and making sure that they have access to care. But the reality is that the stats are clear that it doesn't matter what your income level is. If you are an African American woman who is pregnant, your likelihood of dying in childbirth is significantly greater than if you were a white woman, regardless of educational levels and outcome. And this matters a lot to me in particular because I have a friend who was a PhD and was working at the CDC, had all the health care she could possibly get, and she died in childbirth. I've buried a mother and an infant in a casket together who had access to money and resources and care. So it's not just about lower income women and access to care. Some of this, and I'm going to say this, some of this is about believing women when we say that we need help. And that's not legislation, right? I don't think we can legislate that. But we can, I think, really set and begin to say that out loud, that we need to believe women when they say something doesn't feel right, and make sure they get the tests to see if they have preeclampsia, or keep them in the hospital for one more day and fight with the insurance later about that, right? It's really fundamentally about believing people when they say they need help. And then making sure they have access to the help that they need. We can't legislate that, but we can say it out loud. We can fight for that, and we can start listening to women who are in the legislature and believing us when we say that we need certain things too, right? Like, we can model that on the legislature. But I just want to be clear, and I'm grateful for all the things that we've done for lower income pregnant women. We've made sure that Medicaid will cover telemetry when you need to be observed. So if you live in a rural area, you don't have to drive 3 hours when you're already in high-risk pregnancy. We've done great things. But fundamentally, we've got to create a culture in which people believe women when we say we need help.
Yeah, over the summer, I met with some of the, yeah, go ahead. She deserves that. Thank you. Over the summer, I was meeting with some of my friends, cardiologists, that I did some legislation back in 2017 called the STEMI bill. They were very concerned about the maternal mortality rate in the state of Georgia, and in looking at it nationally and statewide, they were coming up with numbers of 63% of those ladies that did pass away were related to heart or blood pressure issues. In the STEMI bill, we set up grants locally, going back to the community hospitals, that if they would achieve some type of outreach to the women out away in the rural areas, then they would be awarded a grant to help them pay for this. So I'm going to be asking my friend, I've already mentioned it to her, for some money for this program. We have the Office of Cardiac Care, okay, in the Department of Public Health. It does a great job. It's got about $460,000, in funding. I'm going to be asking for $3 million. I don't know whether we can get that, but this is what was suggested to me by the cardiologist. So I think that's a way to improve the outcomes for women, especially those that are removed in great distances from the hospitals.
Thank you. And I think the diversity in the answers to your questions just reflect what a difficult issue it is, but none of us in this room individually are going to solve any of these, but I think it gives me a lot of hope to have legislators like you all in the Capitol. And before I close this out, I would like to make an announcement. This feels like a weird shift. If you have a white Jeep Cherokee that is parked out front, it is going to be towed if you don't move it, so please move your car. And thank you all so much for your time today. They did their homework, y'all, and that is just so incredible, and the work you all are doing is so important. So thank you for your time today, and good luck this session. Look forward to working with all of you. We'll now excuse you from the stage, and we can bring up Courtney Stallworth, Georgians for a Healthy Future's Deputy Director.
Can you all hear me okay? Okay. Well, good afternoon, everyone. My name is Courtney Stallworth, and I have the honor of serving as Georgians for a Healthy Future's newest and first Deputy Director. Thank you. It has definitely been a joy being able to step into this role and witness the incredible work that GHF does every single day, powered by people just like you. And today we've gathered, we've learned, we've been able to celebrate that work as well, but also to ensure that it continues to grow, just like a huge oak tree that's nurtured by its roots, its branches, and its leaves. That's what we started today. Also, if you ask anyone that knows me, they're gonna tell you that I am a plant enthusiast and a wannabe farmer, so bear with me through my plant life analogies that are about to come your way. But seriously, I want to first thank the deep roots of this event. That is our champion sponsors, being Georgia Health Initiative, Hemophilia of Georgia, and Pharma. Your steadfast support anchors this work and really does allow us to flourish year after year. So thank you. And also, just to our generous sponsors, you are the strong branches, really helping us to extend our reach and impact across Georgia. And finally, to our incredible, like none other, GHF staff and team, thank you all for being the green leaves. Thank you for being the green leaves that breathes life into this mission, because your dedication ensures that every Georgian, no matter where they live, has that chance to thrive. So thank you. Now, as I reflect on today, it's clear that the event is not just a gathering, right? It's a forest. And each of you here represents a seed of change, capable of growing something powerful. Whether it's advocating for health equity, supporting policies that expand access to care, or funding community programs, you are planting hope for the future. But here's the thing. Trees don't grow in isolation. They thrive in ecosystems. And you, our donors and advocates, are that ecosystem for us. Your support is that sunlight, the water, and the nutrients that makes our work possible. And without each of you, nothing will grow. So, as you head out today, I encourage you to nurture the seeds of inspiration that we have all gathered today. Take your 2025 nifty GHF calendar, not just because we think they're beautiful, although we do, but so GHF can truly stay with you all year as a reminder of the role you play in building a healthier Georgia. And lastly, I want to end on a challenge for each of you. I am personally challenging everyone in this room to act. Subscribe to our weekly legislative updates to make it even easier, so that you know when and how to lift your voice to protect policies that improve health or fight against those that could possibly harm it for Georgians. And if you're wondering how you can make an immediate impact, watering the seeds that we planted here today, consider a gift to GHF. Your generosity is what keeps this forest thriving. So let's keep watering, growing, and standing tall together. With your support, we can create a Georgia where every person has the opportunity to live a healthier future. So thank you so much, and please, you can exit out this left, your right side of the hall. Thank you for coming out, guys.
Thank you.